Okay, we will get started. Hi, everyone. Thanks for being here today. We're very excited to spend this half a day with you. And there will be a break in our agenda, which I'll show you, but we will be going from 8, obviously 8:05 to noon today. So a little bit of our agenda until 8:10. I'll introduce us all, and then we will have a toxicology presentation by two amazing colleagues of ours in Colorado who are experts on this. We'll have a bit of time for the teams to really discuss basically the psychology of change, which Jamie will be facilitating. Then we'll get a 10-minute break. We will have Dr. Brandy Ring talk to us about inpatient management of patients with substance use disorders. Then we'll have Callan Thornton from the Office of Behavioral Health show us a video about Tough as a Mother, which is an awesome resource that you can refer patients to, and then talk a little bit more about how you can use that resource. And then lastly, in the last part of the day, we'll have one hospital of ours, Montrose Memorial Hospital, talk a little bit about their progress on this learning collaborative and their goals and challenges and successes. And then we'll ask you in a very heavy-handed way to fill out our evaluation survey, and we'll be setting reminders about it too. So if you can't stick around for the whole event, that's okay. On that evaluation survey, you'll be able to say, yes, I attended this one, and evaluate it. No, I didn't attend this session. So even if you can't stay for the whole day, when you see that evaluation survey come through your inbox, please fill it out anyway, and you can just let us know the sessions you weren't able to attend. But we appreciate any feedback for the sessions you were able to attend. It really helps us. So if you could all introduce yourselves in the chat, say your name, your pronouns, and your role or organization, or both, that would be awesome, just so we know who we have with us today. And I think you'll see we have all sorts of amazing stakeholders from all over Colorado, and some people in Montana, people who are in, sort of public health organizations, and then of course, all of our amazing hospital team members. So a little bit of housekeeping. If you're dialing in by phone, please come off mute for a second and state your name so that we know what phone number you are. Or you can put it in the chat as well, just so if we're seeing a cell phone number, we know whose name is associated with that cell phone number. That's really helpful for us. The slides and the presentations will be shared after the day. So you'll receive all of this. Don't need to worry about copying any of it down or screenshotting. If you have video on your computer, we would love to see you. It makes it so much more engaging for our speakers to be able to have a face there and really see your reaction. So we totally understand. We've all been on Zoom for like a year and a half, and it's exhausting. So if you're comfortable and it feels good to you, we'd love to see your face on your video. And of course, I know a lot of you don't have video cameras because of privacy issues, so no worries there. Please stay muted unless you're speaking. You are welcome to put questions in the chat, raise your hand, come off mute and ask a question, whatever way feels comfortable for you to ask a question. We just ask that you stay on mute when you're not speaking. And then we'll have one break. Please stay on the Zoom during that break, just so it'll help us just know who's still around. And so you can, obviously mute yourself, you can turn off the volume if you want, but it helps us if you stay on the Zoom during that 10-minute break. With that being said, we'll get started. Our first presentation today is all about toxicology testing. And I am so excited to have our speakers here today, because they're really the foremost experts in Colorado on toxicology testing in this labor and delivery and neonatal setting. So I will let them introduce themselves, and they're both amazing. And we will start with Dr. Kaylin Klee, who will be kicking us off with our presentations today. And Kaylin, I'll stop sharing my screen and you can share your screen.
Great, perfect. Well, thanks. Good morning, everybody. And thank you for that introduction. I'm Kaylin Klee. I'm addiction medicine and family medicine at the University and Denver Health, and I provide direct clinical care to people with any kind of substance use concern in the perinatal period. Let's do this. And then give me a thumbs up, everybody, if you can see
Thumbs up.
my screen. Great. And then I'm going to try to change it to presenter mode. Can you still see my screen, but just the big slide, not the presenter?
Yep.
Great. Okay, perfect. Well, thanks again. I'm going to kick us off, and then we'll have some time for questions. I hope that this, let me move my camera so I can see you guys a little better. I hope that this topic feels interesting and engaging and not scary. I think sometimes this can feel stressful to talk about with our patients to decide how to proceed with use of toxicology testing. And we'll really do our best today to, I have no disclosures. However, let me say, if we end up talking about certain medications, there are certain brand names, particularly of treatment medications for opioid use disorder, that are most widely recognized by a brand name, but I in no way, shape, or form am promoting one brand and will endeavor to use generic medication names as much as possible unless we need to identify a brand for kind of audience recognition of what we're talking about. Okay. So we'll talk about what is the rationale for using evidence-based screening tools for substance use, screening for substance use, and why do we screen for substance use in general. We'll identify evidence-based screening tools, so some suggestions of what types of tools have been determined to be effective and relevant in the perinatal population. We'll discuss differences between evidence-based screening and toxicology testing, because those are really two separate things. And then we'll briefly examine some ethical and legal considerations when we decide that it's clinically necessary to order maternal toxicology testing. So screening, right? We've talked a lot about SBIRT. Many of you are probably very familiar with SBIRT, but we can't have the BIRT without the S, right? We start with a screening process, and screening really should be used in pregnancy or in the perinatal period to evaluate, just like we do for many other types of screening tests in pregnancy, what we're trying to detect with screening right at the very basic level is a preventable and treatable condition that has some degree of commonality, right? Some degree of prevalence in our population, right? And so if you think about screening that we do routinely in pregnancy, we routinely screen for gestational diabetes, we routinely screen for genetic conditions and cystic fibrosis and some of these other states that actually will have a much lower prevalence in our population than substance use, right? So substance use will always be more common in a population of perinatal people than some of the things that we routinely screen for in pregnancy as part of comprehensive medical care. Screening for substance use in pregnancy has now been recommended by ACOG, by ASAM, which is the American Society of Addiction Medicine, the American Academy of Family Physicians, American Academy of Pediatrics. So we really have, and larger than that, the CDC and the WHO also recommend screening for substance use in the perinatal period. So we really have consensus among the powers that be that this is a worthwhile endeavor to figure out how do we screen and what is our process going to be, whether we're an independent provider in a, private practice, or we're a provider in a large hospital setting. So when we're talking about SBIRT, and I think that we probably all are on this call because we believe in, to some degree, in the power of SBIRT, right, in detecting substance use, providing brief interventions and referrals to treatment for our patients with substance use. we have to start with this screening. And you can see that in Tricia Wright's article that was published a few years ago, she talks about, really screening is to assess for substance use, but also its severity, right? I think where this becomes more difficult is that we can't just screen and say yes or no, right? We can't just say, is there use of tobacco in pregnancy, yes or no? We want to know more about that. Does this person use cigarettes? Do they use electronic nicotine products? Do they smoke 2 packs a day or a cigarette every other week, right? We want to know something about their use because that'll help us determine if that person really will respond to brief intervention or if they need referral to treatment. There's been some studies of screening, right, using evidence-based screening tools, which we'll look at on the next slide. And they found that they've been compared to other modalities, such as chart review, such as toxicology testing. They found that using evidence-based screening tools was the most effective way to determine risk. And this is really important, right? We don't want to just know yes or no. That'd be like, only knowing something about somebody's blood pressure and pregnancy and whether it was high or low. But that tells us nothing, right? It doesn't tell us actually data that we need to act in a way that's going to prevent harm to that person. Because if high blood pressure was, 131 over 81, that would not be the same as somebody whose blood pressure was 160 over 100. And same for substance use. We want to know, is this person using in a way that puts them and their pregnancy and potentially other people at risk? Screening for substance use with evidence-based tools allows for accurate identification of urine or of use during a pregnancy, and actually has been shown to decrease substance use. So this was a fascinating article from Andre Jones, who's probably the leading author in the perinatal addiction world, and was the trial author, the PI for the mother trial, which really established buprenorphine as a treatment medication in pregnancy several years ago now. And she found that actually just having an evidence-based screening in place and having an expert type model where that screening was then reviewed with the patient decreased substance use as a brief intervention. That was kind of a standalone brief intervention, even if that person had no other follow-up, no other referrals to treatment. But just by opening the conversation in an evidence-based way, that people made changes in their substance use during a pregnancy, which is fascinating. She also found during that study that it decreased utilization of urine toxicology tests as a replacement for evidence-based screening. And then when do we want to screen? Of course, we will keep kind of the encouragement that the earlier in prenatal care that we can engage people and screen, the better, but there's no wrong opportunity, right? So wherever people are arriving for care, wherever they're showing up, whether that's a perinatal care setting or not, maybe it's an ER, maybe it's a primary care office, maybe it's their pediatrician's office, right? We'll kind of expand our scope just as we have with depression screening. There's no wrong place, right? But we need to be prepared to have an evidence-based screening tool in place in order to help capture folks who are showing up, not in the prenatal care space or on labor and delivery. These are some examples of evidence-based validated screening tools. And universally really does mean everybody, right? It doesn't mean that we selectively screen somebody because they had limited prenatal care. It doesn't mean that we selectively screen somebody because we saw a note in their chart about an ER visit when they were intoxicated, right? We're not using any kind of predetermined knowledge or judgment about a patient to decide to screen for substance use. We're actually going to screen every single person who is in or around a time of pregnancy using one of these tools as a suggestion. There's other evidence-based tools out there. And if there's something that's already built, especially into your EMR, that can be kind of the low-hanging fruit to pull into a screening protocol. Screening versus testing, right? So this is very confusing, and Lori's going to talk about this a little bit more, because if you typed into Epic or your EMR right now, urine drug, the test that's going to come up actually is called a urine drug screen, right? But that's a misnomer. That's not actually what it is. It's a test, right? It's looking for biologic evidence of the presence of some substance, right? And this varies by type of test. This varies by hospital system, what's, detected in the test that they've created in their lab or contracted for. But urine testing or other biologic sampling, including meconium or umbilical cord, blood testing, hair follicle testing, right? All of these toxicology tests really cannot be used as a substitute for evidence-based screening. As I just mentioned, right, they're often applied selectively, and we have good data demonstrating that people of particularly Black and brown women, people with Medicaid insurance, people with other, social determinants of health that would put them at risk for being discriminated against or stigmatized in the healthcare system, are often overrepresented in toxicology data. And that's not because those people or people groups are more likely to have substance use in pregnancy. It's actually a very distressing sign of institutionalized racism and classism, which has a long history in the substance use and substance use and legal space. Toxicology testing, thank goodness, it does not assess parenting skill or safety or overall function. And really a good example of this, I think, for just, us to think about is, if you had a glass of wine with dinner last night and I tested your urine this morning, you would have evidence of metabolized alcohol. You would have ETG and ETF in your urine this morning, right? Because you ingested alcohol, your liver metabolized it, and your kidneys are doing their good work of excreting those metabolites. But that would not tell me anything about the condition under which that alcohol was consumed. That wouldn't tell me anything about the amount, right? These are positive or negative tests. They're typically not quantitative. It wouldn't tell me anything about your history with alcohol, right? It would just say yes or no, present, not present. And so I think it's good for us to think about that when we're trying to interpret toxicology testing, because it really is a snapshot in time, and it doesn't give us any of the context that we would need to make a determination about severity or risk or diagnosis of a substance use disorder. Very notably, in the DSM-5, the clinical criteria for diagnosing a substance use disorder does not require anywhere toxicology data. There's no criteria that says do a urine test and then that will tell you if this person has an opioid use disorder or a stimulant use disorder. Toxicology testing really has no clinical relevance for making a diagnosis of addiction, which is important for my work. And then there's lots of legal complexity, right? Lori's going to talk more about false positives and false negatives, so I'm going to kind of skip over that. But the legal complexities are really important for us to consider, whether you're an independent practitioner or part of a larger hospital system. Consent is required for maternal toxicology testing. And when maternal toxicology testing is completed without patient consent, it opens us up to potential legal action. There have been several cases successfully prosecuted on behalf of patients who had toxicology data collected without their knowledge or consent, and then had typically some kind of distressing outcome from that, such as being reported to social services, sometimes other civil or legal complications for that person. And those legal cases have been found in favor of the patient. And so really keeping in mind that we have to consent for people using their biologic samples for toxicology testing. The exception to this really would be if somebody was medically unstable, right, unresponsive, and we needed to know some kind of toxicology data as a medical workup because we were not able to obtain history from the patient themselves. What are the possible outcomes when we screen, right? So if we do universal screening, the vast majority of people are going to fall into this low risk category, right? And this is kind of the expert pyramid. The low risk people really still deserve to be screened, because we can't know going into a new visit with a person, we can't know just looking at a person whether they'll fall into this low, moderate, or high risk category. And so those low risk folks really should be encouraged to continue cessation. They should be provided information about particularly substances that are often used in pregnancy without complete knowledge of risk, such as alcohol and cannabis. But they should be congratulated and say, you know, great, excellent. Please let me know if you have any other questions, and provided kind of basic information. The folks with moderate risk, right? These might be people who have a history of substance use, people who had people who had use early in pregnancy, or prior to knowledge of their pregnancy. And then maybe continued low level of use, right? So I would say that I hear this the most from folks with cannabis, tobacco, maybe even alcohol, right? Where they'll say, oh, I've cut down, you know, quite a bit, but really haven't stopped using that substance, and really respond well to brief interventions and motivational interviewing techniques. And then those folks with high risk, right? These are the folks who I'm hopefully going to see in my office. These are the folks who really do have ongoing significant substance use despite efforts to cut down or quit and have not been successful, maybe have physical dependence to a substance, and may very likely meet criteria for a substance use disorder. And those are the folks who should be referred to specialty treatment. What if I don't believe my patient, right? So whenever I give the spiel that we should be using evidence-based screening tools, you know, somebody invariably is uncomfortable with that, because we want, and sometimes the rationale I hear from folks for using urine testing is because, well, what if my patient doesn't report their substance use to me accurately? I feel like I need to have some kind of backup data in case I don't believe that person or they're not telling me the truth. But that feels like trying to have a simple solution to a very complex problem, right? And if urine toxicology testing was the end all be all and actually relevant to clinical care in this space, then I would support it. But it just hasn't been shown to provide any better data than actually using an evidence-based screening tool. And so I don't think by abandoning urine toxicology that we're actually missing much. I will say there are some percentage of people who end up providing a urine sample or other toxicology sample that comes back positive for something we don't expect. And we'll talk about that in a minute. But I would say really the better energy is spent not in refining our toxicology testing, but would be spent in refining our evidence-based screening protocols and our own skill set with setting the stage for having these type of sensitive conversations. I will say this past year in COVID has been fascinating, because SAMHSA, the Substance Abuse Mental Health and Services Administration, really said, you are allowed to stop urine toxicology testing for your patients in treatment, because the risk of coming in to provide those urine samples during the height of COVID exceeded the benefit of continued urine toxicology monitoring. And so many of us in the treatment space have gone now several months, maybe over a year, without routine toxicology testing for our patients in treatment for a substance use disorder. And I gotta say, it is freeing, right? I think the quality of care that I'm providing is better. I think that my patients feel less pressured and scared. The tone of treatment has changed from still that kind of mild probationary tone that treatment can take on when we're asking people to prove their sobriety, or trying to catch them with some kind of substance use by doing urine testing. And I really think it's been a benefit and a step forward. I feel like the quality of care and the deepening of rapport with several patients has been very notable, and that's been reported across many different treatment providers and settings during the past year. There is nothing wrong with trusting your gut, but checking our biases, right? So if you feel like there is something that we are missing, there's something that this person has not disclosed that would be really important, then I think the next step really for me is to check what is it about this person that's got my alert up? And is it something that is based in stigma? Is it something that's based in my own biases, or is it something really something else, you know? And just going through that mental exercise I found to be really helpful. And then asking, right? Taking what I think of as the warmly curious position and asking, you know, what is it about my asking? What is it about my screening that you want to know? Do you want to know why I'm asking you these questions? Do you want to know what our hospital policy is? Do you want to know what happens when a person's been using substances in pregnancy and we're taking care of that person in this clinic, right? Kind of deflecting it from being very personal to just kind of providing more general information to see if you can assess for what might be their hesitancy or what might be their the source of their discomfort. I will say probably the main source of discomfort for people who have disclosed in a limited fashion or don't disclose their substance use, the number one fear is still, and will remain probably forever, that they will lose custody of their child. That's it, right? That's the foundational fear. And so being able to provide accurate information about, you know, what actually does happen, having social services swoop into the delivery room and take custody of an infant is actually, thankfully, a rare occurrence, right? That really is not the process. There has to be kind of a whole discussion, usually involving social work or other hospital personnel, and then a report that can be made. But immediate removal of custody is really reserved for significantly unsafe situations and not for the average person with some substance use in pregnancy. To provide that information, though, means we need to know it. And so if we're going to address the fear of loss of custody, it means we really do need to know what is our hospital's protocol and what is going to happen so that we can speak knowledgeably and clearly about that process. What if toxicology and patient report don't match? So let's say you have some toxicology data, maybe it was collected during a visit, maybe that person was seen historically. Maybe you ask for a toxicology sample and the person consents, and so you collect it. And the patient says, there's no way, that's not true. I never used that. I don't know why that says it's positive. And so this is what I usually say, right? Let's say Katie is my patient and her urine was positive for methamphetamine. And she says, no way, I've never touched meth. I would never use methamphetamine. So I'll say, you know, I want to ask you about that. The urine was positive for methamphetamine. Was there any chance that you were exposed to methamphetamine, right? Not in a, you must have used this way, because as we'll see, there are many, many ways in which we can have discordant testing and patient report. And so just asking, you know, is there a way that you could have been exposed? Sometimes this is a really fascinating question that gives you insight into somebody's home setting, because frankly, what sometimes comes out of this conversation is, yeah, my partner or my roommate, XYZ person is using methamphetamine in my house or whatever, right? I mean, there can be ways in which you get actually some really important information to help take care of this person that actually has nothing to do with their substance use. But this really is where, you know, this is how I propose this to patients. I'm like, really, you know, when you're telling me one thing and this test is telling us another thing, here's the options as I see it. One, this really is that person's urine, but it was a false positive, right? And so the reflex to that needs to be confirmatory testing. We have to have a mechanism in place to be able to take that sample and send it for expanded or confirmatory testing, which Lori will talk about a little bit more, what that means, to ensure that what we don't have is just a false positive, which is very common. The other option could be that it's a patient's urine, it's a true positive, it was an intentional exposure, right? That person knew that they were consuming or ingesting that substance, but they are not ready to talk about it. And really the response to that for me is to continue to work on rapport and safety building so that that person has the opportunity to not be boxed into having this conversation right now, but we continue to work towards, really, I talk about this with all of my patients. I'd be happy to talk about this more, but maybe let's kind of close that conversation, move on to something else, and then we can come back to it at a later time, right? Motivational interviewing cannot become motivational interrogation, right? Like we need to really keep clear in our mind what our role is as a clinician. And for those of you in more of the, child protective services or probation or other legal spaces, that's a different posture. But as clinicians, that's not our role, right? My role is not to turn the spotlight on my patient and get the confession. That's not a clinician's role. And then the other option, it's not patient's urine. So it's either a false or true positive, we have no idea, but it was either a sample mixed up in the lab or that person provided substituted urine, right, which would need to be explored more. And then this is the most concerning, and this is what I say to patients. I'm like, this would be the scenario that really concerns me the most. You actually using this substance and us just not being able to talk about it yet, you actually using the substance and it's a false positive, you actually using the substance or not using the substance, but this is somebody else's urine. Those are concerns, but not as concerning to me as this last possibility, where it really is the patient's urine. It is a true positive that we confirm, let's say, and it was an unintentional exposure, right? Meaning that this person either ingested something without their knowledge. This happens all the time right now with as much counterfeit pill manufacturing as we have in Denver and in Colorado, right? I have so many people who say, oh, I'm taking Xanax, and lo and behold, the only thing in their system is methamphetamine and fentanyl, right? These are pressed pills that are counterfeit. And so the person providing it may not actually know what's in it. But that's really concerning when people have really no idea or control over what they're ingesting. Really important to assess for coerced or forced use, right? I wish that this was not real, but it is so real and so possible, and just really a strong part for a lot of my patients of relationships, of intimate partner violence relationships, some of my patients who are involved in transactional sex work, people who've been involved in trafficking, right? There are a lot of ways that substances may be coerced or forced upon a person that shows up in their urine, but is a very different scenario than that person knowledgeably or intentionally wanting to use that substance. And then discuss harm reduction strategies, right? So when people have a test that comes back for me and they're like, oh my gosh, I'm terrified, I can't believe there was fentanyl in that, talking about, really how do we help protect you from the amount of counterfeit substances that are out there in the community now. And we can kind of talk about this further if people have questions. And then as Lori's going to talk about, we have to have a mechanism in place to confirm any of these discordant results before proceeding with the assumption that it's a true positive. So this is kind of the main question that I get a lot, right? If we test everyone's urine, isn't that universal screening, right? No, it's not. It's not testing, right? I hope I've convinced you, is not a screen. It doesn't tell you anything that we need to know from a screen, which is yes or no, but also severity and risk. We have much higher rates of false positives in toxicology testing than we do in patient report. I will submit to you that I've almost never had a patient report to me a false positive about their own substance use, right? So if people are telling me with their own mouth that they are drinking alcohol or they are smoking fentanyl or they're doing those, using that substance, I am going to take them at their word and assume that that's a true positive report. However, with urine, our suspicion for false positivity has to be very high. And then, of course, since there is a chance of missing some use, right, but we need to balance that against the harm of obtaining non-consented or coerced medical testing, right? Badgering my patient into providing a urine sample or testing against a person's will or consent is harm. And so we have to balance that against the potential risk of missing some substance use using other screening mechanisms. And then confusing same with equitable, right? Even with the same test, even if every single person who delivers a baby at your hospital receives the same urine test, we know very clearly that the responses to the results of those tests are not equitable across socioeconomic, racial and ethnic, and other sensitive and at-risk groups of people. And so we have to keep in mind that by collecting the data, even if we collect data the same way for every single person, how that data is used will be very different. And we have to protect our patients from that. And with that, I will wrap up and I'll stop my share and we'll see if there's discussion or questions. Thank you, everybody.
We don't have any questions in the chat yet, but anyone feel free to come off mute and ask a question. You can put your question in the chat. Yeah, thank you so much, Kaylin.
Has anyone had these types of conversations with patients? And I'm curious if folks want to just talk about, kind of what their experience is like, when it's gone well, when it's not gone well. I'd be curious what other folks are experiencing. I know for myself when it's gone well and not gone well. And I'm hoping there's some camaraderie out there. And it's okay if folks aren't fully caffeinated yet.
I'm also curious, if folks have any fears about what Kaylin is saying, like, are you afraid that if you don't do confirmatory testing or if you don't do toxicology testing, urinary analysis, XYZ will happen? Yeah, I just want to hear more about your reactions and sort of your processes thus far.
Let's talk a little bit about that. I have this is Michelle. Sorry, my camera is not working. Yeah, I have these conversations all the time, and I like when they go well, and when they don't, I hope that our program is continuing to do what we feel is the right thing, and that is just, like Kaylin said, building that rapport, just moving forward with that relationship, because I feel that we can build that they will share more with us, and that seems to work. When we design a program, we're going to do drug testing and home visits, and I'm really glad that there was a lot of red tape within our facility to be able to do that, because now I'm really glad we don't do that. Our patients are in our program because they have a substance use disorder, and they're typically being tested by several other entities, and I just ask them, how was your screen, or we just have a conversation about that. So that's a little bit about our interaction with our patients in our program.
Thank you for sharing, Michelle.
I was just chatting in. It's Jamie. I'm curious, and maybe you can just answer in chat if you're not on video or able to come on audio, but like Kaylin mentioned, quote unquote, universal screening and every patient every time when it comes to talks and things like that. What are y'all currently doing? Is it everybody? Is it based on your gut? Based on previous medical history?
Hi, Jamie. This is Lisa Becker. I think that now that is a work in progress. We just, with this project, actually have started to use the verified tool. But it's so interesting doing this because even this last month, for example, we had a patient who came in for labor, and she had her care at an outlying clinic, so we didn't until the next morning have records for her. But she divulged, substance use as a teenager and up to 2007. And then not after that. And I said, that's great. And what made the difference for you? And she said that having kids made the difference for her. She's got custody of her children and everything. But because of that history, the nurse, when we did our checkout in the evening with the team, said she has this history back in 2007 and she needs a drug screen and a cord stat. And I'm like, why? So, there is a lot of inconsistency in what all hospitals do. And I think that this project is so valuable in trying to create some consistency, try to reduce bias, think about the reasons why we're doing what we're doing.
Yeah, that's a good example, Lisa. I appreciate you sharing.
It's a journey.
Yeah, absolutely.
Yeah,
Go ahead,
I will
Kaylin.
say too, I think that, this is really fascinating. When I was mentioning about like COVID changing our urine toxicology, even for people in treatment, right? So this is like the select group of people who we are all in agreement that they have a significant substance use disorder. Even for those people, reducing toxicology has been beneficial. But I will say, honestly, with the current substance milieu in Colorado and increasingly across the United States, our hospital toxicology testing has not kept pace with what's actually being used. So fentanyl, right? Number one opioid being consumed, non-prescribed right now in the country, is not ever going to be detected by a urine toxicology opiate screen. Never once. It's a synthetic. It won't be positive. And same with now a lot of different like designer or counterfeit benzodiazepines. And other substances, right? Ketamine, DMT, a lot of substances that are commonly being used by people will not be detected on a substance use or a drugs of abuse screen, right? If what, and Lori will show in a minute kind of a couple different hospital examples of what's in that drugs of abuse screen. So I would also say, don't be falsely comforted by a negative, right? I mean, as much as urine can tell us true things, it's increasingly more likely to falsely reassure us. And what we're actually more at risk of missing when we lean too heavily on toxicology testing is use that's going on but not detectable. And so the only way to really assess for that is with validated screening and either, paper, pencil, computer, or face-to-face conversation.
Kaylin, I love that. And I think the term I keep hearing in one-off conversations is conversational screening, right? Like really focusing on having a conversation with the patient. And I know we're going to talk about this throughout the day today. We saw with hospital data collection and information sharing individually that hospitals are really challenged in terms of available time of their team to have a conversation, especially when we're focusing on a labor and delivery unit, someone's in active labor, it's like a race car pit crew, everyone's like rushing to do their thing. Sometimes time is of the essence and it's hard, to have a conversation and get all the pertinent information. And so we'll talk a little bit today about small test of change, if it's not on admission, at least at some point before that patient is discharged and going home, sharing valuable information, getting them resources, asking questions, having that conversation. So sounds like you mentioned, Lisa, it's a work in progress, and we'll talk more today about how we can we can all kind of work through that together step by step and do some small changes that hopefully incrementally get us there over time. So lots to consider in a busy labor and delivery unit with a ton of stuff going on, but really important to have conversation, it sounds like.
Absolutely. I mean, I think it has to, for providers, we have to get out of the mindset of, okay, now we call case management and that's it. That's not where I want to be on our unit anymore. So,
yeah. Great feedback.
Thank you, Kaylin. I can't wait to meet you in person.
I know at Valley View, we are currently only do urine screens on people with no prenatal care. If they have been screened in our clinic, we know the patients, we don't screen for urine tox hardly at all. We do get permission, but that's what we're doing here. Otherwise, we ask, and that's how we do it. And yeah, unfortunately, we still have the old way. If you had a history in 10, 20 years ago, we still do a screen and we send the cord. So yeah, we need a lot of catching up.
Yeah, thanks for sharing that, Mick. Well, we can move on to our next speaker, Laurie. And Laurie, feel free to share your screen. And then, of course, we'll have more time for questions after Laurie's presentation as well.
Awesome. Thank you so much, everyone, for the opportunity to talk today. Let me see if I can get this into presenter mode. Maybe. Okay. Can you guys see that?
Great.
Okay, perfect. Excellent. My name's Laurie, as you guys all know. I am a pediatric hospitalist and medical toxicologist. I primarily work at Children's, but I see tox patients actually at multiple hospitals across the Denver metro area. And I also help staff our poison center, the Rocky Mountain Poison and Drug Center. So we get calls there across multiple states, actually. And not infrequently, we get called in some form or fashion asking us to help interpret a urine drug test. I should say I'm going to focus on urine drug testing in this talk because I think that's what's most commonly used. But what I'm talking about today is really applicable to tox testing in general. So it's really not specific to urine, although that's the term I'm going to use since that's what most people are pretty familiar with. So no disclosures. Some learning objectives. So we don't have a ton of time to talk about a topic that is very near and dear to my heart today. So we're going to be pretty focused in our chat, but I'm happy to answer questions, outside the scope of these objectives. And certainly if something comes up that we want to discuss further, feel free. But this is what I kind of have on the agenda today. I want to be very clear because there has been understandably quite a lot of confusion around this term screening. So before we move forward, you'll see screening already on this slide, several times. What I'm talking about today is called a screening test. And I'm going to try very hard to use those terms together so I'm really clear about a screening test, not a verbal or conversational screen, which is what Dr. Klee was primarily discussing. I wish I had another word to use because I think screening test is a bad term that is misleading, but unfortunately that is the term. And if you call the laboratory or, look up, scientific articles on this online, this is the term that's used. And so unfortunately, we're sort of stuck with that nomenclature right now, but I'm going to try really hard to say screening test and not just screen, because screen is very misleading and not clear. Okay, so with that, let's talk a little bit about what drug testing in general can tell you. So a drug test might, emphasis on maybe, might tell you if a patient was exposed to a particular substance or a class of substances. So importantly, many drug tests cannot tell you about which substance in a particular class the patient may have been exposed to. For example, benzodiazepines. We know there are lots and lots of benzodiazepines out there, and many drug tests cannot distinguish one from another. More importantly, Kaylin Dr. Klee, I should say, did address this quite extensively in her presentation, so I'm not going to kind of harp on this point. But drug testing many times will not tell you lots of really important things, like who, what, where, when, why, all those contextual factors that are much more important, frankly, than the exposure itself. And certainly much more medically significant, right? Just because a patient was exposed to some degree to some substance is essentially meaningless information without the context of that exposure. And certainly, like, if you put all the social stuff aside and think just medically, at minimum, from a toxicology perspective, we want to know something like the dose of exposure, and a toxicology test, certainly a screening toxicology test, will not give you that information. So there's much to be desired here. I think the last point I want to emphasize on this particular slide that, again, Dr. Klee touched on, but I think is really important, and we get called about this quite a lot, is drug testing cannot tell you under any circumstance whether and to what degree a person was intoxicated or impaired. And we get called all the time, basically from people hoping that we have a magical, insight hat that is going to allow us to interpret this and, somehow divine that information. And we cannot. That is not something that these tests can tell you. So I just want everyone to be really clear that under no circumstance is a test going to give you that information. So already I've started to paint this picture that testing is really limited in its capacity to give you information. But I think this is a slide that's really, really important to understand, because when we talk about drug testing, I think a lot of people sometimes conflate these two different types of tests. And it's really, really important to understand, if you're talking about testing, which type of test you're talking about, because they will actually give you very different types of information. And in some cases, one type of test might actually be useful to you, whereas the other test is not, and you don't want to be ordering the wrong one. So tests come in two sort of categories or buckets. There are screening tests and confirmatory tests. Most of the time when we talk about drug testing, most people are talking about screening tests. So when you talk about a urine drug screen, that's a screening test. When you talk about, I should say, any sort of drug testing that is going to give you typically a qualitative result, like a positive or negative result, that's almost always a screening test as opposed to a confirmatory test. Most screening tests are immunoassays. So for those of us that are clinicians who are nerdy and remember back in the day, learning about like laboratory techniques and stuff, most of these are immunoassays. And because they are immunoassays, they are subject to numerous false positives and false negatives. And we're going to get into this a little bit more moving forward. But, understand that the idea here is that the company that's making the test, that's making the reagent, is basically creating an antibody that is designed to bind to some portion of the structure of the drug in question. And they can decide basically how good a match they want that to be. And it's a tough thing, because on the one hand, obviously you don't want it to be such a poor match that it's going to, bind to 10,000 other proteins that have nothing to do with the drug in question. But you also don't want it to be so incredibly tight and specific that you may be only testing for a very specific, individual pharmaceutical agent when you may want to be testing for the class. So if you want an opiate screen, for example, if you can create an antibody that is extremely specific to morphine, but then it's not going to detect any other opiate, right? So it's this fine balance between wanting it to be specific enough, but not too specific. And unfortunately, that's a really, really difficult thing to do. And as a result, we have tests that are basically not very good at what they're supposed to do. That said, they're used really commonly, as we all know. That's the whole point of us being here, right? And that's in part because they're cheap, they're fast, they don't require a lot of training to use them, and they're everywhere. They're really readily available. That is in contrast to confirmatory tests, which are generally speaking much more sort of fancy technology. So HPLC stands for high performance liquid chromatography, GCMS stands for gas chromatography coupled with mass spectroscopy, and LCMS stands for liquid chromatography coupled with mass spectroscopy. These the details doesn't matter. The point is that these are very, very technologically savvy, highly accurate, highly precise tests that essentially, for the sort of purposes of this discussion, don't really have the problems with false positives and false negatives that screening tests do. That's why they're considered confirmatory. They should confirm the result that was sort of presumptively obtained from a screening test. They also almost always will produce quantitative results, which can give you a little bit more information than just a yes, no, present or absent type of result that you get from a screening test. But they are very expensive. They're slow. Sometimes turnaround time for these tests can be on the order of weeks, which is not usually very clinically relevant to people. And typically part of the reason they're slow is that it requires almost always sending out. So most hospitals don't have, gas chromatographs and mass spectrometers sitting in their lab. That's just not something that is going to be used very often. And so most hospitals don't invest the gazillions of dollars that it takes to buy one of those. Okay. So I'm going to take a pause there and just, I know we're supposed to do questions at the end, but sometimes this does create questions. So I wanted to take a quick pause. If there were like immediate questions on this topic, now would be a great time to jump in. And if not, we can move on.
Yeah, and absolutely no pressure to hold questions to the end. We love interjection questions, and we'll go the whole time of the presentation plus discussion, regardless of when you ask the question.
Perfect. I didn't want to mess up the agenda,
No,
but
you're good. Thank you, Laura.
Very low-key, happy to take questions anytime. Okay, I may move forward, but if people do have questions, just pipe up or stick it in the chat. I can't see the chat very well from where I am, but I'm sure that Katie or somebody else will let me know if a question.
Yeah, I'll let you know.
Cool. Okay, so as was sort of alluded to in the title of my presentation, urine drug screening tests are complicated to interpret, and they're very nuanced. And I find that often what scares me the most about these tests is that people don't necessarily recognize that nuance and complexity. And they sort of take the result as gospel, like it says positive, therefore it is positive, or it says negative, therefore it is negative. And that could not really be farther from the truth. These are really, really complicated to interpret, and they are deceptively complicated, right? Because the result looks really straightforward. There's not like a bunch of numbers, there's not a reference range, but these are much more difficult to interpret, in my opinion, than like, an elevated CRP or something like that. So we're going to talk about a couple of points here in the coming slides. So the first is that what you find depends on what you look for. And I think a lot of people mistakenly assume that whatever their hospital has in terms of its sort of standard urine drug screening test is the end all be all. But that is certainly not true. And I'll show you that in a minute. Cross-reactivity, which is what I was alluding to earlier when we were talking about the antibodies that are used in immunoassays. Cross-reactivity means that the antibody is supposed to, is designed to bind to drug A, but it actually also binds to drug B, even though drug B was not the target of the antibody. That's what cross-reactivity means. So we're going to talk about how that's a major problem and how that leads to false positives. And the last thing, which I'm not going to delve into moving forward because I think it's a relatively straightforward point, but I want to make sure that you guys understand, is that there is a threshold, so to speak, or in other words, a minimum quantity of drug present in somebody's urine, blood, whatever the matrix is that you're testing, that you have to have in order to make the test actually read out as positive. So you can have a situation where a patient in fact was exposed to drug A, and the test is designed to look for drug A, and the patient really does have drug A in their urine, but they have drug A in their urine at a concentration that's low enough that the test will not read that out as positive. It's going to read it out as negative because it's below, I'm making up numbers here, but it's below 100 parts per million or something like that. And that threshold amount varies from test to test, from brand to brand, from hospital to hospital. So you can have the exact same sample run on different assays and get different results, which is scary, right? So I want everybody to know that and internalize that. And fear that should hopefully instill in you when you're trying to interpret these, because you're making big time decisions on information that's not very complete if all you have in front of you is just this little piece of paper. Okay, so let's delve into these top 2 points a little bit more so you guys see what I'm talking about. So what you find depends on what you look for. I mean, again, this is sort of like an obvious statement, right? But I think a lot of people don't realize the diversity of testing options that are out there. So what I've listed here are the 3 hospitals where I see tox patients clinically. And I can tell you as a medical toxicologist that anytime I am consulting on a patient and the provider says, well, I've ordered a urine drug screening test, so you'll get those results soon. I would say more often than not, maybe even the vast majority of the time, I will sort of curiously ask, why are you getting a urine drug screening test on this patient? Because the bottom line is half the time the results are garbage. They're just not useful to me. I have so many other things in my arsenal of information that's much more valuable to me than the answer to this test. And certainly at certain institutions, so at Denver Health, you can see, for example, their sort of standard urine drug screening test has only 5 target analyte groups, so 5 sort of topics that it's testing for, so to speak. And as we'll see in a moment, a lot of these are subject to tons of false positives and false negatives, such that I don't really care what this tells me. It's just not going to give me anything very valuable. Even if something comes up positive, I'm going to question if it's real. If something comes back negative, I'm going to question if it's real. So why would I bother sending that test, right? Now you can see at Children's, for example, they have a much more robust standard, air quote standard, meaning like the default option. If you just type in like a urine drug screen test, this is what's going to come up. And part of that is because the pretest probability of something being positive in a toddler is very different than it is in an adult. And so we are, in many respects, a little bit more willing to tolerate the nuances and frankly not very accurate results that we get from these tests, because in a young toddler, sometimes we don't have a lot of other information to go on, especially if they don't come with a historian with them. They're not going to give us a history. And so we're sort of flying blind and really looking for information anywhere we can get it. But as Dr. Klee mentioned, anytime we get a result back that we, for whatever reason, are concerned about or question, we follow that up with a confirmatory test, because we know that the results from this original screening test, there we go, the results from this original screening test are in and of themselves not particularly useful. So unless you are prepared to follow up whatever urine drug screening test you're going to send with the confirmatory test, I would hesitate to send the screening test in the first place, because it's not going to give you what you want to know. And if you're planning on sending a confirmatory test after every urine drug screen that you order, I would hope that you're not ordering, dozens of these every week, or you're going to get a call from the lab because you're sending a whole lot of expensive sendouts. This should be something that in sort of best practice is very selectively applied. And sometimes that is totally appropriate and should be, obtained. But it should not be a sort of shotgun approach to patient care. This is a big deal. So this is, again, just a snapshot of how diverse hospitals can be in terms of what they offer in terms of their air quotes standard urine drug screening test. In addition, let's talk a little bit more about cross-reactivity and what that means and how this can be so problematic. So again, what I'm talking about here is when the makers of these tests are creating these antibodies that are, again, designed to bind to a particular drug, we call that the target analyte, meaning the target that the test is supposed to be looking for. To give an example, as I mentioned before, opiate screens, often many makers of opiate screening tests, I should say, are targeting morphine as their target analyte. So they are designing an antibody that is going to bind to morphine, and you can see the structure of morphine there on the left. The thing is, that there are lots of other non-morphine drugs that are similar enough in structure that most of the time, those antibodies will also bind to those similar structures. So as an example, you can see the structure of hydromorphone, which is dilaudid, next to it. And it's really similar, right? It's really just at the bottom here. I lost my cursor here. Right around here that you see a little bit of change, right? But otherwise, those structures are nearly identical. And so most of the time, many times, the antibody that is designed to look for morphine will also bind to hydromorphone and will create a positive if there's enough hydromorphone present that it exceeds that threshold that we talked about that will make the test read positive. However, an antibody that is designed to look for morphine is almost certainly not going to bind to fentanyl. And you can see why. The structures are completely different. There is no homology there. They are not the same, even a little bit. And so it doesn't really matter how bad of an antibody, so to speak, it is. There's just no similarity there. It's not going to bind. And fentanyl, as Dr. Klee said, is one of the major problems we're seeing right now in terms of substance use in Colorado and actually across the country. And yet, none of the tests at these 3 hospitals are going to see fentanyl. So that's a big problem, right? If that's one of the most common substances that people are going to be exposed to that has a medical implication, and we can't see it on the test that we're sending, that's not great. So similarly, you can have a problem where a patient might be taking a medication therapeutically as prescribed, but it is similar enough in structure to the target analyte that a test is going to read positive for example, amphetamines, when in fact, what the patient is taking is their appropriately and normally prescribed ADHD medication, which many of them share the same amphetamine backbone as the target analyte for most of these screens. So this can be sort of a double-edged sword and very problematic in that the cross-reactivity can both give you lots of false positives, and the lack of cross-reactivity across opioids, for example, like I've shown on this slide, can not give you a positive even when there is in fact an opioid present. So here, I want to even go deeper into this kind of problem and demonstrate to you that it's not just about the individual molecular structures. It's also about, like we talked about, how exactly the makers of these tests design the antibodies. In other words, how tightly do they want this to bind? How precise do they want that antibody to be? Because like we've talked about, if it's too precise, you miss things that you don't want to miss. But if it's not precise enough, then you get too many false positives. So this is, the numbers don't matter here. This is just to show you sort of visually that across brands, so Cedia and Seva, these are different brands of makers of basically urine drug screening tests and also the reagents that go in the test. So they're basically the people making the antibodies, essentially. They can and do have pretty significant differences across these different sort of testing platforms in terms of the cross-reactivity. So what you're seeing here is specifically for the amphetamine screen. And you're seeing here that there's lots of drugs that have some amount of cross-reactivity with a true amphetamine, which for those who want to be really nerdy is a phenylethylamine backbone. That's the structural backbone. So these all have some phenylethylamine backbone component, but only some of these are actually amphetamine, right? So L-amphetamine is amphetamine, D-L-amphetamine is the racemic mixture of amphetamine, and the rest of these are not actually amphetamine. They are just analogs of amphetamine. And you can see that there's a wide range of cross-reactivity across not just in individual, like one column, how much one particular drug may cross-react with the amphetamine screen. But even you can see, like, for example, pseudoephedrine or Sudafed at that bottom one on the last line. For the Cedia systems, that's not going to cross-react but the SEVA system is going to see that exactly the same as amphetamine. And so this is what I'm talking about, where if you take the exact same urine sample of a patient that took Sudafed that morning and you run it on a CEDIA platform, that's not going to be positive for amphetamine. But if you run it on a SEVA platform, it will be positive for amphetamine. And that is a big difference, right? So we want to be really, really careful about how we interpret these tests. Okay. This is my last slide, which I will probably nerd out for a while, but just so you guys know, we're in the home stretch here. And then hopefully we'll have some time left over for a little bit of discussion. So this is in no way, shape, or form a comprehensive list. In fact, I had to pare down my already not comprehensive list substantially to make it fit on the slide and still be legible. This is a very, very tiny little bitty snapshot of a few things that can cause some urine drug screening tests to be falsely positive, some of which we've talked about already. So like ADHD medications and decongestants causing a false positive amphetamine screen. We've talked a little bit about, actually we haven't in this talk, but a lot of people are aware of the fact that TCA screens are notoriously pretty bad at actually detecting, TCAs and TCAs alone. And there are lots of other drugs that can cause a TCA screen to be positive. But I want to point out some that a lot of people don't know about. So first of all, there's a common myth out there that cannabinoid screens or screens for a THC metabolite are extremely specific, and that they are reasonably specific, but it's certainly not foolproof. So there are regularly prescribed medications that can cause a false positive for some assays for THC. In addition, methadone, I'm seeing this happen a lot at Children's actually, because we have methadone as a target analyte on our urine drug screen, as you guys may recall from that slide a few slides ago. I would say in my time at Children's, I've seen, certainly dozens, if not hundreds of urine drug screens sent. Not infrequently are those positive for methadone, and the number of times that the patient actually ingested methadone was one time. So as you can see, like diphenhydramine, for example, is a common cause of a false positive methadone screen. Lots and lots of people use diphenhydramine, that's Benadryl, and they probably aren't even going to tell you that because it doesn't seem relevant to tell you that they took a Benadryl yesterday. Like, why would they share that with you unless that was somehow relevant to their chief complaint? So unless you're taking a really thorough drug history to include over-the-counter preparations, supplements. So Ma Wang is on here, for example, as a reason that amphetamine screens might be positive. But there are tons of other supplements out there that can cause various drug classes to be positive on a screen. Not to mention that in the US, supplements are not regulated such that you in fact have no idea what you're buying, and sometimes maybe purchasing something that you did not understand you were going to be taking. This can become very difficult to interpret, right? And so I hope that I have convinced you guys that just because a urine drug screening test says positive certainly does not mean that the patient in fact ingested or was exposed to a drug in that particular class. And on top of that, because again, I had to cut this down to make it fit on the slide, I didn't even include on here all of my false negatives. But there are so many classes that may not actually show up on a urine drug screening test, even though you want them to. We've talked about how that can happen with opioids, particularly synthetic opioids like fentanyl. They are not going to show up on your opiate screen. Another really big problem child with that is benzodiazepine screens. So many benzodiazepine screens are designed, the target analyte, that thing that the antibody is designed to bind to, they are designed to bind to a particular metabolite called oxazepam that unfortunately is not actually a metabolite of very many benzodiazepines. So lots and lots of benzodiazepines that people use all the time, like alprazolam, for example, which is Xanax, that's not going to show up on many brands of a urine drug screening test that uses that particular target analyte for their benzodiazepine screen. So again, you are really risking getting information that's not particularly useful to you. And I hope I've, sort of demonstrated that given how complicated this is to interpret and how much sort of uncertainty there is in these results, you are so much better off talking to the patient and sort of going down the pathway that Dr. Klee set out for you to get much more robust information that is way more reliable, frankly, than what this is going to tell you, unless you're planning on sending a confirmatory test after every single one of these. And I think that approach is much more likely to reduce harm, because you can see how much harm you're going to cause potentially by getting particularly a false positive. Even if you ultimately end up confirming that it's not a true positive, that's going to take potentially weeks, as I've already told you. Confirmatory tests can take a long time. And that patient is going to be pretty scarred by that experience, I would imagine, right? By the time that gets sort of sorted out, a lot of times social services is already involved. Sometimes there has already been a removal, which is problematic. Not so much in the neonatal period, but this happens sometimes with older children. And we want to be really, really careful about understanding what the repercussions of this can be, particularly if a confirmatory test has not been sent or hasn't resulted yet. So I'm just rambling at this point. I'm going to zip it and see if there are questions or comments or thoughts that we can sort of move forward with. Thank you all.
Laurie, this is Jamie, and wow, that was so interesting. I felt like for a minute I was back in organic chemistry and learning about all this. So really, really interesting. And I'm curious, maybe not so much a question for you. You might have some experience in working with the hospitals that you mentioned, but for those on the call, who's interpreting these tests in labor and delivery, and what's their training? It sounds like, you have to really understand what you're looking for and be able to interpret that and then apply that. So I'm just really curious, across the board, hospitals across the state, those on the call, like who's charged with interpretation, and then, next steps based on that interpretation, and how are they trained?
I would certainly welcome thoughts from anybody on the call. I can tell you in my anecdotal experience, this is a really interesting phenomenon, like nationally. So locally here, anecdotally, it seems like most of the providers that are either like on L&D or on the pediatric side taking care of the babies typically essentially interpret these themselves. There are other places in the country where essentially 100% of these get sent to a medical toxicologist for interpretation, which is just, I don't really have strong feelings about that either way. I think all that matters is that the person doing the interpreting understands what they're looking at. But I do think it's interesting how that has pretty different like regional sort of cultures around it.
Yeah, that's very interesting. Lynn asked a question. How can we get a list of potential positives? This is fascinating. I don't think many of us realize this.
Yeah, so I can certainly send out a list of like common ones, but I want to be really clear that these are not exhaustive. And just like, technology advances, labs get different, they may decide to change their particular brand that they're using or change the reagent that goes with that brand. And they don't have to tell you, which is super scary, right? Like every single, and I mean, this sounds sort of intense, but this is my job. Every single time I'm interpreting a drug test, I call the lab and I ask them, what's the brand? I want to see the manual that goes with that brand. Because the manual will have some information about things that the company already knows may cause false positives or false negatives, but it's not exhaustive. It's not like the company is going to test every pharmaceutical on the market to see if there's a potential interaction or what's technically called interference, if there's interference. So the sort of approach that I personally take, and granted, this is the mindset of a subspecialist, and I don't expect everybody to do this. But if somebody is, if you're actually concerned that something may not be accurate in terms of your screening test, there we go, you should not only talk to the lab, talk to the person who's running the actual assay down in the lab, who has access to the manual and can get all that information, but also checking the literature, because people publish this, it's like literally, it feels like every week there's new reports out about whatever, assay, and turns out that, efavirenz in fact does cause a false positive on this particular assay for THC metabolites. And like, no one knew that until somebody figured it out and reported it. So it's a lot more complicated, I think, than people realize, which is part of why I'm really careful about who I think should have one of these tests sent. That said, a really good place to, I think somebody mentioned this, Lisa mentioned this in the chat, a really good place to start and a simple measure is to call the lab, because they are generally more aware than most of the clinicians are, not just in terms of what testing they're using and whether or not there's been a change recently, but also, they have access to some of the like predetermined information as far as known interferences.
So this is Lisa again, and it's just fascinating, and it kind of makes me feel like most urine tox screens are completely worthless, and I'm trying to see, when we would actually get value from that based on the knowledge that you guys have given us today. Is there like a national organization that has ever done a statement about this that could be disseminated to providers to make them more aware of all these problems?
That's a great question. I know that the American College of Medical Toxicology has some information about sort of interpretation of urine drug testing, although I don't know that it's necessarily geared exactly towards, like the perinatal population, which is, I think, a unique population in many respects. I'm curious, I don't know, Kaylin, do you know if ASAM has anything out there?
I mean, I think there isn't, as far as a statement kind of discouraging use of toxicology testing, there isn't that, because they really can serve a true therapeutic purpose for people in treatment, in prevention. I mean, there can be a role for this, right? So there isn't really, that I'm aware of, a statement discouraging use of urine toxicology when it's appropriate, but there is, as you mentioned, a ton of data in the medical literature. I mean, if you even Googled right now, urine false positive methamphetamine, you'd have hundreds of articles, publications, case reports documenting that this is a well-known phenomenon. And then Brandy, as she's commenting, I was just going to chat this, Brandy, you're so, yes, really is that ACOG ACOG, I think, has made the strongest statement about kind of moving away from urine toxicology as being a clinically helpful tool for screening purposes, right? So I'm not talking about, and umbilical cord testing, those are the expanded panels. And so those really are much more accurate. So I'm not talking about all testing, but I'm saying for screening purposes, these really are fraught with concern. I will say the other thing I wanted to mention before I'm going to have to jump off in a little bit is that the other folks who have a lot of trouble with this are the social services caseworkers that I talk to all the time. They don't have any training in toxicology. And really often when I'm talking with caseworkers, I mean, I have this conversation probably 2 or 3 times a week where somebody's saying, help me understand this umbilical cord, help me understand this urine, this patient's urine. We're going to court this week for a patient of mine with no confirmatory urine testing ever having been completed, right? And so there's really big problems when these tests kind of are done just reactively, and there's not great understanding either in the medical community or in the social services, civil or legal community about how to interpret these tests. And so I talked with some of our local social service caseworkers about like, what do we need to provide them so that they actually feel comfortable managing this data? Because they are equally uncomfortable in my experience with receiving these reports. So.
And I did want to just emphasize something that Kaylin just said, which is that there is a role for testing. I don't mean to say that testing is always wrong or never appropriate, but I think that role is much more limited than we sort of have traditionally experienced it to be. And so, I mean, you know, I'm a fairly new graduate myself, and I can tell you, having trained fairly recently, like very much the culture was still that this was a totally reasonable thing to send on like virtually every patient because it was cheap, it was inexpensive, it's non-invasive, and what's the harm, right? And there was no training on the harm. So I think that's the bottom line, is that these are very powerful tools in terms of potentially causing harm, and don't always give you the information that you want to receive. And I think that is the nuance that really needs to be part of the conversation. Not to say that these are horrible and should never be used.
Yeah, I think that's really important. And for those who are able to access chat, some great comments about what other hospitals are doing, right? Referencing the lab, like we heard Lisa say, some good information there about Brandy included ACOG's opinion about this. And I think a lot of consideration, right? About when is the right time for screening tests. Lori, I'll make sure I say that correctly. And, you know, when is conversational screening, you know, coupled with that, and how important is that as we think about the process and best practices across all of our hospitals and caring for our patients. So super helpful, super interesting. Thank you both, Kaylin and Lori, amazing content. I know Katie put in the chat, we will share all of these slides and all the pertinent information, resources in our newsletter. So if you haven't signed up, she put a link in chat as well. So we can follow up with folks that way. You'll get the information if you need anything, info@cpcqc.org. We'll make sure you get all of this information in your hands. Any other last minute thoughts before we move on to actually now like applying some of what we've learned today and how we can make some changes in our areas?
Yeah, I want to just reference, so this doesn't get lost. Oh, Val's comment about the Colorado Tox Guide for social workers and other like non-medical clinical workers is really helpful. And I still find that there's caseworker discomfort with having this kind of plopped in their lap as like, I have to interpret this. And so the more that we can support caseworkers with the knowledge that we have, coupled with the resources they have, I think is a good plan.
Yeah. Thank you, Kaylin. Great last minute comments there. So we will move on. I know, Sam, I see a chat coming in. Right, so definitely having deeper conversations, relying on with connections to the patient, right? And ensuring, I love that, right? Patient partners, ensuring that our patients are partners in their care, and we're having conversations, sharing information, and being transparent. So great way to wrap that up. Thank you again, Kaylin and Lori. Amazing content today. Thanks for sharing. Thanks for guiding the discussion. And with that, we will transition into our psychology of change. So this should be fun. I'm gonna share my screen in just one moment here. Make sure I've got this up right. All right, and Katie, if you just help me keep an eye on chat, feel free to interrupt me. Hopefully this will be engaging so people don't need to wait for Q&A. This is how I wanted to start things because when we think about the psychology of change, we think about, why is this so hard? We know change in this particular circumstance, it makes sense. It's the right thing to do. We know that patients are dying from overdose and suicide in the perinatal period. It's one of the top deaths here in our state and nationally in a lot of other states as well. And so we know that screening, brief treatment and referral to intervention and treatment is critical and it works. And so why is it not happening consistently in every hospital and every prenatal visit all along the continuum of care in the perinatal period? And so today we're going to talk about why there's an implementation problem. We're going to talk about why it's so difficult to actually disseminate and scale this protocol or this process, and how we can actually translate the idea of conversational screening into the real world and how this might look different in each different setting with different resources. And so just to make sure you're all awake, I do see some chats coming in, but I'd love for you all to just, no thought, just reaction. Do you like change? Yes or no? Simple answer. I like change. Yes. I like change. No. Katie says no. I'd be the one on this couch with my therapist saying, well, I like change if I'm the one driving it. so my answer is circumstantial. So I see Brandy saying sometimes Allison likes change. Susanna, no, which is interesting because many of you are here as the agents of change, right? You're the champions of this project. So Callan thinks she likes change. I love it. Callie's embracing it. That likes results. Great. So keep them coming. This is fun. But you see, we're all different, right? And the answer is not always yes. Emphatically, yes. So let's talk through how together we can bring about change in the labor and delivery unit. Sorry, my clicker. There we go. Okay. So thinking about the psychology of change, we need to co-design our change to be people-driven, right? And so those affected by the change have the greatest interest. And I love some of the comments. So instantly, those of you who work in a labor and delivery unit go to, well, this impacts my day-to-day work, right? If you're a social worker or somebody from a different lens, you're thinking, yes, this, what we're doing, this conversational screening, this screening testing, all has a down the road impact on my role. Maybe I get a phone call and I need to consult with a family who has tested positive during pregnancy, and I need to provide support services or make assessments. Thinking about the patient, right? This is a person who shows up, is pregnant, about to deliver, and all the conversations and the things that we do have an impact down the road. So we have to think about everybody being part of the change. We have to understand our bias. Being vulnerable is really difficult, especially a lot of the folks here on this call. You're in a successful clinical role. You're looked at as somebody who has all the information. And so it is very helpful to stop and reflect and think about, can I identify my own bias? I'll be vulnerable and say, before I came to this work in the maternal child space, before I had friends and family who had substance use experience and challenges with that during pregnancy, I had a bias. I was one of those people who said, wow, how can somebody use drugs when they're pregnant, right? That would impact their child. And so getting information, learning more, listening, and building relationships allowed me to step outside of what I knew and be more comfortable and learn and change my bias. And so I would challenge you all to reflect on your own bias as you work through this, and to identify bias in your colleagues, in your coworkers, and how you engage your patients through this process. It's really important to understand who the actors are. So as I mentioned, that includes your patients, that includes your colleagues, that includes the leadership of your hospital. So think about that when you're trying to actually implement a change and make a shift happen. Why is engagement so hard? Well, as you can see, this isn't my priority. This isn't going to affect me. I don't know how to change. I don't know why I'm changing. So it's really important to understand. And again, if you just engage me on chat, what are some of the things that you feel that you've encountered when either you yourself are resistant to change or somebody that you're working with on this project is resistant? Maybe just a one word. Why do you think they're resistant? I know one word for me that always comes to mind is stubborn. So I'm a stubborn person, and so change is difficult. So if you just play along, pop in chat, what are some of the things, the one word, the one feeling that you think that either you yourself or someone you've encountered along the way when you're trying to implement change? Why do you think they're not engaging? What do you think is one thing that is keeping them from being part of the change? Awesome, Allison, thank you. Lack of comfort, right? Fear. Yeah, you get different images. People are scared. Like I said, I'm stubborn. So feel free to keep chatting those in. It will be interesting to see what everybody's either personal opinion of themselves and why they fear change or what they've encountered. And again, we won't associate it with you directly. So Katie, right, loss of control, right? That's a big one. Good, thank you. Okay, so keep those in mind as you think about who your champions are and how you can engage them and who your resistors or laggards are. So things that we can do to understand people and how we can help them move along and change with us are will, execution, and knowledge. And so one of these that I think is really important is, starting with will, right? Do we want to change? Do we have the desire to change? The second part of that is, what do I know about this that would make me want to change? And so I want you all to think through that as we go through this exercise in our team time today is, what information or data would be helpful for your physicians, for your staff, for your patients, that we could actually share this information and they would think it's meaningful and it would be respected. So it would essentially get their buy-in and have them come along on this change ride with us. And what acceptable sources could we use? So we talked about tox screening and we had resources, right? People were saying, well, what is ACOG's guidance and what is ASAM's guidance? So think about that as we walk through this process together. What information, what resources do we have that people on your team think is respectful and they would recognize and want to understand, and that would help them change their will to change. They'd have the knowledge, and then we could move to execution with them. So we'll think about that through today. Again, looking at professional organization guidance, data that exists, what do we know, why is screening for these diagnosis important in the labor and delivery unit and before discharge. So this is just a visual. Think about who comes to mind. It's interesting because I thought a lot of you on the call today would say, oh, I love change. I'm in that innovators section right over there on the left. But as we see, that's a really small percent of people, right? And then we need to bring along our early adopters. And as you can see this curve here, we're going to have laggards that are a certain portion of people that really are hard to bring along. So as we walk through exercises today, think about who your laggards are. I would anticipate, even though a lot of you said that change is not your favorite thing, that you don't like change, you must be somewhere in this innovator early adopter section, or you wouldn't be dedicating your time today to this phone call. You wouldn't be leading an effort to implement screening protocols and practices in your unit. So I'm guessing you don't give yourself enough credit, but you're somewhere in that innovator early adopter section. And we're going to talk about how to bring along other people in this change today. Callie, before we go to the next slide, if you would, Callie or Katie, go ahead and launch our first polling question. We just want to do a little bit of temperature check here. So we're going to launch a poll, and if you would just take a moment to read through it and answer it, and then we'll see the results real time. We are curious if you would share with us what you think your greatest barrier is to implementing screening. We've collected data and we're going to share more about that. Let's see, maybe I have to launch it. Okay, there we go. So hopefully everyone can see that. Katie, looks like you can see it. Okay, perfect. So if you would just humor us, what do you consider, and I know all of these are real, we saw this in your data collection, so just pick the one that you believe to be the greatest barrier to implementation of screening for substance use, anxiety, and depression. And we're including all of them. We're gonna break out a little bit more of these here very shortly. But we're just curious, which do you think is the greatest challenge? Again, acknowledging we've seen all of these in your data collection. So hospitals that are participating, thank you for sharing. All right, we'll just keep this open for another 10 or 20 seconds here. Looks like things are moving up and down as people are entering. So far, we've got tie for provider buy-in and the electronic medical record with a close second here. I'm going to give y'all just 5 more seconds. If somebody hasn't answered, that would be awesome if you could provide your input. If this is applicable to you, obviously, what is the biggest or greatest barrier? All right, we're going to end polling and results. So you can see here, tie for provider buy-in and the EMR with a close second there, knowledge of and/or navigating community resources. Too many questions to cover and staff capacity also acknowledged. So thanks for participating in that. We're going to focus a little bit more on some of these as we go to the next steps today. Okay, so another visual. Our QI coach shared this with us, and I thought it was really relevant and helpful when I think of an image of how we want you all to think about implementing change in your areas. So we want to be like the dolphin, right? So we want to come up frequently for air, taking short, communicate with each other, and ensure contact with the rest of the pod, right? So we're going to do small incremental tests of change. We don't want to be the whale, taking a very deep dive, trying to hold our breath and gain a lot of traction and distance in one fail swoop. So today what we're going to walk through together is how do we do these small tests of change that are fundamental in quality improvement? We are going to make changes based on hunches, theories, and ideas. They do not have to be perfect. We are testing them. They have to be manageable. And so we want you all to get away from the mindset that we're going from not screening to 100% screening. That is not going to be successful. We're not going 0 to 60. We have to go from nobody doing it to one person does it to many people do it, and then many people do it to all people do it. So we want to start with those people we talked about that are champions, early adopters. We want to practice with them. We want to take a leap and say what might work well for you before we scale that. So we want to do the PDSA cycles that are fundamental to quality improvement work. We want to, maybe you try this with one patient, just start small, right? This patient seems willing, we have time during this admission process. I'm going to walk through the screening questions. I'm going to be transparent. I'm going to have a conversation about why we're doing this, and I'm going to get their input. You know, how did it go? How did you feel? And then we move to another patient and we make adjustments along the way. Maybe you've got one champion doctor who is like, this is amazing. I'm on board. Let's test this. And they say, I'm going to do all my patients. And I'm going to see the variation across patients based on their admission situation, based on their medical history. And I'm going to make adjustments and then give information back to the team about what worked well and what didn't. Maybe you pick a day or a week. You don't need buy-in from everyone, and you don't need to start with everybody, right? So just do tests of change. Pick easy changes. We know EMR is an issue. We saw that from pretty much everybody who completed their data and in their 30, 60, 90-day plans is like, this would be ideal if we could build out our EMR and we could put all these questions in there and then we could track them, and we don't have a pen and paper, but it costs money. We have to put in a change ticket, so on and so forth. And so really what we want to think about is the EMR, that's great. That's pie in the sky. But today we are going to start with pen and paper. What is actually doable? And then we'll keep analyzing that data with you. So we're going to just spend a couple minutes on this exercise so that we can all give input together. And we are going to walk through, we're going to skip project name, but we're going to go ahead and walk through this exercise so we can all make sure we're very clear, because those of you on the call today are the leaders. You're the change agent, whether you think so or not. You're an innovator, you're an early adopter, you're here for a reason. And so we want to make sure that we all are clear on like, why are we changing? What's the purpose, right? What are we trying to accomplish? And then what are we changing? And I want you to think small. I don't want anyone to put down screening, comprehensive universal screening for every problem there is. But what are the things that we are changing that we can do in small tests? And then who are the people involved? So we're going to do a quick Jamboard session. Let's get this up for you. I think Katie, are you going to pop Jamboard into? Perfect. All right. Katie is going to pop Jamboard link. If you haven't done Jamboard, we'll give it a minute just to test. We are going to play this game together. And you will have the opportunity to input just sticky Post-its, whatever you want to call them, just like we were in person back in the day before COVID. And we could all participate and everyone could give input and kind of put your ideas on here so that others can learn from what might be working well for you or what your ideas might be. And then we can move to helping you implement these small tests of change. So go into your chat. There's a link you'll see from Katie. If you just click on that link, you'll be taken to a Jamboard that looks just like what I've got here. You'll be able to do annotations, like I mentioned, stickies, and this is all confidential. As you can see here, we're all different animals. We're anonymous, so nothing will be associated with you directly, so feel free to be very candid. And on the left-hand side, if you can see my cursor, you can do a pen, you can do a sticky note. If somebody already put an idea that you had up, you can just take your pen and put a +1 or put a check mark or a star. You can do all sorts of stuff. But go ahead and just have fun with this for just a couple minutes. This is going to be our Q&A and our collaborative like team learning together. So feel free to chat things in if you're not comfortable with Jamboard. Come off your mute or video, throw ideas out there and ask questions too about this as we go through. So I see someone's got expert training in there. So right. So just think about the project name, really screening, brief interventions, referral for treatment, right? Like that's the goal here. So go ahead and start to fill in why you think we're doing this, our purpose, different particulars. Again, think small, think really, really small. I'm going to implement this with one doctor, with one nurse, with one midwife. And who are those people? And don't forget all the actors, right? Even the laggards. Who are the people that we need to bring along during this change testing? And again, don't feel like you have to know Jamboard. You can chat it in and you can come off mute. And I'm gonna, I know we're gonna hear from Montrose. I think Jana is on the call, and they're gonna share some of their test of change and some of their successes and barriers. So I won't steal your thunder, Jana, but feel free to like chime in if there's anything in particular. I've seen all the data from everybody's 30, 60, 90-day plans and all that you've input. So I know there's some great stuff happening and we'd love for you to share that with this group. And we also know there are some barriers, right? And some of those were identified. But this is a great time for people to share their pain so others can commiserate with you. We know this isn't easy. And we also want you to take about 10 steps back and think about small tests of change. So not going from 0 to 60, just implementing incremental, small tests, seeing how they work, learning something, and then making adjustments along the way. All right, we see some ones. So thank you. I think Katie's she's a Jamboard rock star. She's moving some stuff around here, but some good things here, right? I'm seeing we want to set mom and baby dyads up for the best chance at good maternal child health outcomes. So right, that's huge, huge. Providing resources for patients, another big one, right? If nothing but that patient leaves knowing that they're not alone, that there are resources, there's something that they can reach somebody or someone they can reach out to get more information and get help after discharge, that's critical. See locating peers, right? All right, we've got staff, nurses, clinical staff providers, LCSWs. Does anyone want to put patients in that column? Our patients? key people in the change cycle, right? Patients. Has anyone tried that? I'm curious. Has anyone tried, being upfront with a patient and saying, hey, you're obviously not in active labor, probably not delivering in the next, 30 minutes. We have some time to talk, going through history and things. Has anyone tried to say, we're trying out this screening thing. We've got some questions to ask. How open are you to going through this process with me and sharing your feedback? Is anyone brave enough to have tried that? Patience, thank you, someone put it. I love this. So also, right, purpose, right? Support patients in recovery. That's a great purpose, right? We want to support our patients. We can't improve a problem we're not willing to have, right? We have to ask in order to offer help. So we have to know. I love that somebody, said the purpose of this is to identify potential issues and refer people and get them the support that they need. So I think most people seem to be on the same page here. A lot of great comments coming in. All right, I'm going to call on a few people and I hope they don't hold this against me later. Amy Dempsey, I'm curious because I know you personally. Don't hate me later. If you're answer, I've seen your hospital do amazing things with quality improvement work, and you've been engaged with CPCQC for a number of years. Anything that you all have done that you feel like works really well in terms of like a small test of change? Like, how'd you even get this thing off the ground? Amy might be multitasking on the unit. Anybody else? Mick or Jonna, maybe if you want to share. I know Lisa, Michelle, just curious if you've just tested one small test of change that seemed to have gone well or fell flat on its face. We'll take either.
We are really just starting in Valley View, and our women's health is starting there, getting things going slower there. And we just agreed on a whole what to use to screen patients. So that's where we're at. We're pretty, I think I would say, low in it, but we want to make sure before we start, we have our resources in place so that when we do screen, we know we can then do something about it. Because if we screen and we have no data, then we're a little worried. So I think we want to just make sure we have resources in place before we start our whole big process. But I think it'll kind of fall into place quickly. It's seeming to go a lot faster in the last couple of weeks. So I feel like we really have some momentum coming.
Awesome. Great place to start. Megan. Did you come up mute, Megan? Maybe unintentionally. All right. Thank you, Mick. You're right? You want to feel like you have all the information before you get this started and you have the resources. With that, we'll launch a really quick poll while people are still putting in comments and ideas, because I think this is important too. So your feedback would be really helpful here, because you led me perfectly into this, Mick, is what is your comfort level in responding to a positive screen, right? And this is, again, the conversational substance use, anxiety, depression screen. Because for those of you who are the champions, who are driving this change and seen as people who have resources or can help get this implemented, I think it's important for you all to feel comfortable, right? If not very comfortable. And I'm seeing as the poll, as people are like providing input here, it's pretty split with uncomfortable, neutral, and comfortable. And so I would just ask that you let us know, your peer group here, CPCQC, your technical supporters, what information could help you get to that next level. So if people would take just a couple of seconds to pop in your answer there of what is your comfort level in responding to a positive substance use, anxiety, and depression screen in your unit, I think that would be helpful, because that might be a place we want to start together as a collaborative, is do we have all the information? Do we have good information? Do we know where we would refer to, so that if we find out a patient is having challenges in any one of these areas, that we feel really confident that we've got the resources and we can do a brief intervention and refer them for treatment. Because otherwise, we've heard from you, there's a fear in screening. So we'll leave that open for just another second here. If you could go ahead and weigh in on your comfort level in responding to a positive screen in your unit. All right, so interestingly enough, about 50% of you said you're comfortable, about 33% said feel neutral, and 17 feel uncomfortable responding. So that is very informative, and I think we need to keep that in consideration as we work together in the coming months to really figure out what resources we need to get to all of you and to your colleagues and to your patients, that hopefully when we reassess that in a number of months, people will feel very comfortable that they have the right resources, they have the right information for themselves and for their patients. All right, sounds good. Okay, well, thank you for participating. I was just checking chat. It looks like Callan has to hop up, and then she'll be back to join us to share a video in a little bit. And we are just at the end of the hour. So we'll wrap up with our team time session 1 and turn it over to our next presenter. Katie?
Where's mute? Hi. Yes, thanks, Jamie. And we know we promised you all a break. So we're sorry we ran through that time. If you need like a bio break, feel free to, we can take like 5 minutes, so until 10:05. And give you a break, and then we'll start at 10:05. So that gives you 4 minutes to grab whatever you need, grab water, snack, head to the bathroom, and then we will get going. So we're sorry about that, but think that the session Jamie was leading was too important to cut off. So thanks for your patience. Oh, Brandy says, give them 10 minutes. I'm in no rush. Okay. 10 minutes it is. So come back at 10:10 and then we will get started. And then I will put on the screen just when to come back. I will change. Sorry, I have my tabs confused. Okay. I will make this say 10 to 10:10. And then you can come back at 10:10. Okay, so we will move on to our next presentation. The presentation is going to go until 11 a.m. So with that, I'm going to turn it over to Dr. Brandy Ring. She will introduce herself, but she will be presenting on safe opioid prescribing and preventing and treating substance use disorder for the OB-GYN patient. So Dr. Ring, I will stop sharing my screen and you are welcome to start sharing yours. And Dr. Ring, you are muted.
Yep.
Just
Can
in
you
case you
see and
didn't
hear
know.
me now?
Yes.
Excellent. Okay. So I'll go back here. So again, Brandy Ring, I am actually down in Houston, Texas at Baylor College of Medicine. But I was in private practice in Denver up until about 2 months ago. So nice to see and hear some familiar voices and faces. I'm going to talk to you a little bit about some of the overview about safe prescribing, prevention, treatment, all of these things, and introduce a fantastic new resource that we just released. All right, so my disclosures, I was a member of the Colorado Cures editorial board for the OBGYN section, and I am a member of the Baylor College of Medicine faculty, and all my opinions are all my own. Okay, so I'm going to introduce you to this, what we call the Colorado's Cure Project. So in 2019, a bunch of different organizations led by the Colorado Hospital Association, the Colorado Medical Society, and the Colorado Consortium for Prescription Drug Abuse launched this initiative to try and bring together all sorts of different specialties to get some best practices for the whole of the medical community. And what has resulted from that is a series of guidelines that are available online to everyone. These are not behind a fire or a paywall, that you can access about best practices in opioid prescribing across the spectrum. We just released the OBGYN guidelines, yay, in April. And these are specific to our patients and to our population. So for all of you that are doing projects of some way, shape, and form, these are there for you. Now the entire document is 184 pages. I don't anticipate you're going to sit down and read that, by the TV at night. But if you've got a project specifically focusing on something, looking at each of these sections is going to be helpful. So I'm going to outline some of what the sections are and just make you familiar a little bit with this resource for you. So brief overview, okay, it's broken down by 3 kind of sections, which is limiting opioid use, multimodal approaches to care, and harm reduction. But it is comprehensive for all sorts of different patients, hospitalized, obstetric, outpatient, all of those. And at the very end, there are some policy and practice recommendations to use. There's patient handouts, educations, and then some ways we can advocate for change. And the biggest thing and the huge benefit of this is not just from OBGYN primary literature. This took in evidence from anesthesia, from general surgery. We worked with our dental colleagues, our pharmacists, to really get a comprehensive guideline from everybody's best practices. So table of contents, you can peruse this. It is included. There's a link to it so you can see, but you can also Google Colorado Cures and it'll come up. But if you're doing a presentation like this one, there's tons of graphs that you can borrow and you can look at the most recent data in OBGYN, the most recent data in Colorado. And this just underscores the importance of the work that everyone here is doing. These are broken up, so you have key elements of systems. So if you're trying to implement a new ERAS protocol, if you're trying to figure out which populations you should target, these are all in there. And then it's going to give you some options for changing practice to do better in terms of limiting opioid use. These are just what some of these guidelines look like. There are links throughout the entire document to millions of resources. There's like 12 pages of references. So all of these things that give you some best practice guidelines if you're setting up new programs. So here's the link. All sorts of great stuff in there. Fantastic resource. Please, 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 please use it. Particularly relevant for Colorado, there are some sections in the anesthesia guideline on anesthesia considerations for cannabis use, so check that out. It's very eye-opening. All right, so I'm going to kind of use this through the lens of this new resource for you to talk about some of these best practices for you. So the multimodal pain section goes through surgery-specific guidelines. And I figured for everybody here, the most relevant one would be to go through our cesarean guidelines. So ERAS, if you're not familiar with it, yes, enhanced recovery after surgery. I know many of the Colorado hospitals have already implemented this, but this gives you information about where this came from, why we're doing it, how we assess if it's working. The cesarean protocol will go through all sorts of things. It'll go through preoperative considerations. So what medicines do you give preoperatively to these patients? What could you give? How do we change practice to reduce pain after these procedures? There's going to be a section that is going to then go over intra-op. So what can we do? Do we have anesthesia's ability to do tap blocks for patients that have higher pain tolerances or didn't get good pain relief from a past procedure? Are there other options that we can do? It's really funny coming down here to Baylor. We actually do tap blocks for all of our C-sections, which is a new protocol for me, but it is part of their protocol to try and reduce opioid use. They give you recommendations for post-op. How can we schedule our pain medications to reduce the use of opioids, including both Tylenol, ketorolac, but also opening up to things like lidocaine patches, which many of us aren't familiar with using. And then they give you some options. So when kind of what you're used to using isn't working, or if you're allergic or something like that, we have other options, and what could you use? This is for discharge, so it gives specific discharge recommendations. How do we continue a good pain regimen when people are at home without being our primary prescription reliance on opioids? And then each of the sections has a special consideration. So this is particularly for our opioid dependent patients. So this is for pregnant patients that have opioid use. What are we going to need to do to adjust them so that their pain is controlled, but that we're also not interfering with their maintenance therapy, that we're really doing patient-centered care here. So brief overview, very good information, very detailed, great resource for anybody looking at a specific procedure in these. So these are the detailed pathways that exist for OB. We have first trimester miscarriage, labor and delivery, post-vaginal delivery, and C-section. For GYN, we have chronic pelvic pain, vulvodynia, dysmenorrhea, and ovarian cysts that are specifically laid out as I've gone through them. The second section is on harm reduction. So many of you are familiar with a lot of these. We talk about, kind of trends in OBGYN. There is links to all of the treatment or drug drop-off centers, so for safe drug disposal take-back programs. But really, we as providers should be doing these things. We should be trying to reduce bias and stigma. And I know that we heard that earlier, that we have to battle our own biases first in terms of who is an opioid user in pregnancy, because it's not who many of us have preconceived notions about. We need to work on preventing overdose, so going through naloxone prescriptions, providing fentanyl test strips to make sure that if people are going to use, they're doing it in the safest way possible. Dose education, we need to talk about, after a successful period of sobriety, or non-use, they can't go back to using a dose that they were using before, right? They're more likely to overdose, and we need to keep people safe. We talk about routine infection testing, and that's for both sexually transmitted infections as well as associated use infections. So based on the mode of how they're using medications, we need to make sure that we're taking care of that. And then we need to take basic care of these patients. We need to refer them to treatment, mental health treatment, take care of that. We need to have the conversations about, if their prescriptions or their opioid supply is not from a prescription, how are they getting it? Are they trading sex work for these opioids? Are they in a situation where they're experiencing intimate partner violence, or are they a victim of trafficking? And how do we identify and help that? And then, of course, just making sure that if they are using injection for these opioids, can we get them into needle exchange programs? Or there's been a lot of discussion about some of these safe injection sites as well. And then really the bulk of what I want to focus on is really this focus on treatment of opioid use disorder. So opioid or substance use while pregnant, first we need to identify it. And it looked like some of you have some ongoing fantastic projects on how do we identify this, right? How do we screen our patients? You guys just had a fantastic talk on, hey, maybe, just urine drug screening is not the way that we should be screening these patients. But what else can we use? So there's some validated screening that you can do. It sounds like a couple of you are working with the SBIRT, the Screening and Brief Intervention Protocol, which is fantastic, supported by ACOG. But don't forget, you also need to screen for things like tobacco and alcohol use, and screen for coexisting mental conditions. And then it is recommended in the second, third trimester to rescreen. Right? This may be a new problem. This may be a coping mechanism for the stress of pregnancy, but more likely this is something they didn't feel comfortable disclosing to you in the first trimester, right? And so rescreening, they may be more comfortable with you as a provider, with your a way that you approach their care. And most importantly, it is not too late. It is not too late to get these patients into treatment. We really have to be respectful of care across the diversity spectrum. SBIRT is really good about this, but these are 6 principles of trauma-informed care that we need to pay attention to. We need to make sure that patients feel safe, both psychologically and physically, that they view us as being trustworthy and being transparent. We have to tell patients, hey, we're going to screen you for alcohol, drugs, smoking, right? This is why we do it. We have to engage their support network. We know that folks that go home and have support at home are more likely in every single treatment aspect for all chronic diseases. Diabetes, high blood pressure, they do better if they have someone at home helping. And we really need to collaborate with other providers. Most of us are not experts in treatment of substance use disorders. And so we need a treatment team that is, we need a labor and delivery team that is, and we need to make sure that we are communicating well with those teams. And then we really need to empower patients, right? In this area, it's very common to come from a we know better than you perspective, and you have to do X or you have to do Y. And the reality is that you're sitting with an autonomous human that can make their own decisions. And they may not be the decisions that you would make, but it's not our place to judge those, right? We need to support them where they're at and really make sure that we're giving their voice power. And then, especially in OBGYN, we have to be very careful about the cultural, historical, and gender issues that we have. OBGYN has a history of excluding populations for good care. And we need to recognize that when they come into our doors, particularly our Black and African-American population, they don't trust us, and for good reason. And we need to check our biases, but we need to understand that they're going to have some hesitancy coming forward. And so we have to be really aware of that. Now, there are some patient handouts included in here that are fantastically helpful for prevention or for helping, to try and assess how at-risk people are keeping things safe. These are all fantastic. There's also screening tools. So if you decide that you want to use, instead of the SBIRT, some of these other screens, those are included. But the main point is to have a protocol, right? Pick one protocol that it works for your institution that you can use very easily. And then we have to treat, okay? The recommendation from the American College of Obstetricians and Gynecologists is medication-assisted therapy is the mainstay of treatment, okay? We don't recommend withdrawal in pregnancy. People get too unstable. We don't recommend that. And depending on how the patient is doing, when you identify this as a chronic medical trouble for them, depends on how you can get them into treatment. You can do outpatient treatment. Even in pregnant patients, they can be started on maintenance therapy as an outpatient. And many, many places are moving to outpatient therapy, particularly in the first trimester. And particularly if they've already gone through withdrawal with buprenorphine, they can do that as an outpatient. And actually the recommendations on buprenorphine, you can do outpatient starts even in the second and third trimester, right? Because they've already gone through the dangerous part of withdrawal. If you're starting methadone, it is still most common to have those start as an inpatient, especially in the second and third trimester. There's a resource down here at the bottom. If you are not familiar with your medication-assisted therapy clinics, you can find a clinic if you move to a new place that is a comprehensive list there. Included are 2 different protocols. These are quick start protocols. There's one for methadone and there's one for buprenorphine. So if you're looking at how you might be able to accomplish a new protocol at your institution, this is a fantastic way to do it. So you can quick start in the emergency room. You are going to have to coordinate with your emergency room docs for them to give methadone in the emergency room, right? And so that may be part of your care coordination and part of your program, if that's where you're trying to work on. I think one of the big things you have to really pay attention to with any quick starts that are inpatient is the hours of outpatient maintenance therapy locations. We have many locations in the Denver area, but some of them won't take new patients on the weekends. So if you have met someone on a Wednesday, they're not ready to go home till Friday, they're not going to see them on Saturday. They won't see them till Monday. And so is your patient really going to be able to get their methadone maintenance for the weekend? Maybe not. And so take into consideration whether when you're considering inpatient versus outpatient protocols, that life is different on the weekends and we have to account for that. Here's the protocol for quick start buprenorphine. The big thing with buprenorphine is you either have to already be in or through withdrawal for buprenorphine to start, or buprenorphine can precipitate withdrawal. And so we have to be very careful. And it's been one of the reasons why the uptake hasn't been as quick in pregnant women. It is safe, it is an acceptable option, but the uptake hasn't been as strong because of that period of having to have a withdrawal. It is sometimes a little easier to use though for patients. So patients who come in on buprenorphine therapy, we do not need to change them to methadone. They can remain on that therapy. Okay, so how are pregnant patients with substance use different? The bottom line is they aren't, okay? But their chronic medical disease is different. This is different than a patient that comes in with diabetes. This is different than a patient that comes in who has high blood pressure. So you need to treat the patient the same way you would every single other patient, right? But you need to think about how their disease affects their care. So bottom line, addiction is a medical condition. It's not a moral failing. And we need to meet patients where they are. We have to infuse empathy and respect into their care. And substance use disorder affects all races, all socioeconomic groups. We cannot judge a person by what they look like to say, yes, you have a substance use problem or not, okay? However, the chronic medical disease, right? And the way we explain this to patients, their disease is centered in their brain, right? But it affects their entire body. This is a chemical trouble and a way that their body responds to certain chemicals. With this particular disease, relapse is common, but relapse does not make someone untreatable, right? If someone stopped taking their blood pressure medicines for a month, you wouldn't say you never get blood pressure medicine again, right? You'd restart them on their blood pressure medicine. And the same with this therapy. And with treatment, brain function, cognition become normal, okay? Adequate treatment is treatment for this. And we know screening is often biased, right? It's biased by provider bias and these misconceptions. We know that African-American women get screened at 2 to 3 times the rate of white women, right? And for no other reason than the color of their skin. We need to fight those biases and why those screening protocols for everyone need to be universal and universally applied. We do see this more when we do urine drug testing. It does tend to test people who are of lower socioeconomic status over those who aren't. And so universal protocols when you're developing them are critically important. So when we're counseling, you have to be respectful. I mean, we've all heard stories of this terminology being thrown around the floors. Maybe we've heard it ourselves. We need to use the lessons that we're learning from our diversity trainings to say no. We need to intervene as bystanders and say, that's not appropriate terminology for my patient in this room. Here's the correct terminology, and I would appreciate it if you would not use that anymore. We need to stand up for these folks because maybe other folks haven't had the training that we have. So how is pain different in pregnant patients with substance use? Well, they aren't different from normal patients. They still have pain. They still have complications, and they may actually have more pain, and they may have higher rates of complications. And some of that is due to the bias we as providers have for them. They also have other comorbid conditions, right? But they have more medication interactions. So we need to be careful when we're prescribing medications for other conditions that they don't interact with maintenance therapy. Each of these patients responds to stress in a different way with different coping mechanisms, just like all our patients do. But in this particular disease, stress can be a trigger for relapse. And so we need to pay attention to that. How is anxiety different? Well, They experience depression and anxiety around pregnancy, just like all of our new moms and our new dads. They have anxiety about being a good parent. They have anxiety about the process of labor and delivery and newborn care, and they have breastfeeding anxiety. The disease, right, means that some of our anxiety medicines might interact, right? We know that these patients get reported to CYS or Children in Youth Services at higher rates for reasons other than their substance use. And they're not substantiated more, they're just reported more. And we know that newborns may require different care, different interventions, maybe NICU stays. You do need to counsel these patients. Breastfeeding is strongly encouraged, but if they have a relapse, right, then we need to have a cessation of breastfeeding for a time until we can get them retreated. How is labor and delivery different? Well, it's not, right? We still need trauma-informed and racially sensitive care. We need to pay attention to who they want in the room with them. We know that data in the African-American population has supported that having a support person that's non-family, a doula, improves outcomes, right? All outcomes, healthy outcomes for mom and baby, they can be critically important in this population as well. They need good explanations of procedures. They need to know what you're doing, why you're doing it, and how it's going to be done. They need fetal monitoring. They need vascular access, just like everyone else. But their disease may make it difficult. They may need alternative coping mechanisms because the medications that you usually would use might interact, right? Or they may not want to take them. So we need to have pain plans in place. Fetal monitoring can be impaired by methadone and buprenorphine treatment. We see minimal variability more commonly, and we see lower baselines. And so we have to take those fetal traces into account. And vascular access can be more difficult, so sometimes we need to pre-plan that maybe we need an ultrasound for IV placement, or we might need to place 2 IVs in preparation in case one is unusable. All ways to keep your patients safe. So how can we help? Well, we can switch to using functional pain scales instead of numerical ones, right? Someone's 6 is not everyone's 6, and we know this from everyone that comes into labor and delivery. But using functional scales, today I can't get out of bed, versus, today I can walk around the room, is a better indicator for pain and whether they need additional pain medicines. We can do education on our NICU processes and treatments, what neonatal opiate withdrawal syndrome looks like, so patients know what they're looking for. We can encourage breastfeeding. This is commonly controversial, and it shouldn't be. Breastfeeding is important in these patients, and we should be helping them and providing lactation support. However, these patients might need some help. We might need to change their environment a little to decrease some sensory things for the newborns, and to make sure that we're following these guidelines. The new Eat, Sleep, Console guidelines have a lot of sensory things that we can do. So here's some different, our traditional kind of pain scales. But the functional pain scale really switches us to where is it? What type of pain is it? What is it preventing you from doing, right? And then we can use these to kind of gauge when we need them, these more numerical values. We know that NOWS is increasing. We've seen this in Colorado. There's our numbers there. We are still in kind of this medium to high range. And so we need to educate patients on what to expect. So here's your table of your signs and symptoms. I find this is really helpful to explain to patients that these are processes that are central to the brain. It's not, one thing. It is all of these neurotransmitters that are very complicated. And this kind of helps patients to understand exactly what's going on with each of the medications that they've been using. We have non-pharmacological treatments for infants. These are focusing on mostly the behavioral activities as observed. There's some scales that our NICU and neonatologists use to see if they need treatment, but really we're trying to move away from even treating infants as much now. So the Eat, Sleep, Console is something I like to educate patients on, that this is our primary way to treat babies, is to try and make sure that we're just giving them the comfort and the care that we would to try and reduce their use of medications, just like we do with moms. Patients are doing really well with these. We had really good luck when we introduced this at Rose for not having babies be in the NICU, but to have them be able to stay in their rooms with moms. This is what we can do on the nursing floor to help We can control the environment. We can control how they're feeding. We can control their social integration. This is all for babies. But if you think about it, this is all really good for mom too, right? Like, who doesn't want to like kind of relax in a room that's a little more quiet and a little, you know, prepared for us? All of these can really help both the stress of babies, but also the stress on moms from those NICU admissions. So this is a soothing position for baby. There's a video on YouTube if you want to watch it. It's kind of hilarious if you haven't seen this. The pictures make it look really, you know, strange, but it actually works like a charm. So if you ever have a chance to try it, it's great. So again, breastfeeding, beneficial, right? We actually have decreased severity of NOWS because yes, babies get a tiny bit of whatever mom is on in breast milk, but it's not nearly to the extent of what they were getting while they were inside. And this helps to have a slow withdrawal or a slow taper for babies as well. We need less pharmacotherapy. The infants stay in the hospital less. And we all know the importance of attachment, particularly with these patients where their stress level is really high. And then we can't underscore the immunity that's conferred right now, especially with the infectious disease environment that we're in right now. So we do have some, you know, best practices. We shouldn't have any other contraindications such as infection that they might pass to infant. And again, if they have a relapse, we do need to counsel them that we need to suspend breastfeeding because we don't know the other substances that may have been, particularly in when our opioids are obtained from a non-pharmacological or pharmacy source. Here's some data on the numbers, how much is in breast milk. All of these studies, right, have shown that these levels are significantly less significant than we ever would think they would be in infants. They're not going to have really like any pharmacological effect, but we do detect them. However, codeine and tramadol, we need to be very, very careful with because those are actively put into breast milk and can cause lethargy in the infant. So here's the treatments for now. If you're interested, I put it up there for you as a resource. Again, we're really trying to get away from this. There are multiple other projects in Colorado right now really trying to reduce the use of opioids. There's a new program starting up to try and get naloxone in the hands of pregnant women. And so, you know, thank you guys for taking on a lot of these projects, for being involved in them. You know, when we all work together, we can really help to reduce this risk of misuse and diversion. So last piece I'll talk about is just advocacy. You know, we need more support. We need some more support nationally. When we published this, we were like, get rid of this X waiver. It's going to be terrible. And then they got rid of the X waiver. Way. So you can use it. You still do have to file a notice of intent, which is basically an application that says I have the support and the resources and things to be able to provide this to my practice. And you are limited to 30 patients, but it is hopefully going to maybe break through that barrier a little bit to get some more providers to provide. And then, of course, we have these health data sharing policy issues. So we need to be able to share their care when they are experiencing substance use disorders. So here's a whole bunch of the other groups that we've worked with, you know, great folks out in the communication and out in the community that we communicate with for all of our folks. And I will then pause there and open it up for questions.
Brandy, it's Jamie. I'll start with a disclosure. I'm not a clinician. Most people on the call know that, but I'm just thinking about some of the comments and conversation we've been having with some of the participating hospitals. I know your focus in the conversation today, the topic was substance use, but you know, we're looking at substance use, anxiety, and depression, and you know, comorbidities that exist. And there's been some conversation about like the best timing for the screening for those various diagnoses. And so do you have any ideas about, you know, we're hearing people are challenged to try to screen for everything on admission, you know, it's such a busy time. And there's different aspects of what we learn from the screening, you know, specifically with substance use that might be different for treatment versus anxiety and depression. And I don't know if you have any like ideas or what you've seen worked well, or maybe even not work well, as far as the timing of the different types of screening for different diagnoses and what that might look like in a labor and delivery unit, from admission to discharge. So if you have any ideas, comments.
Yeah, so I think that the bottom line for everything is screen often, and if you're not sure, screen again, right? So you can do these in multiple ways that are quick in your office. So you can do screens just on your computer at check-in. And that can be your initial screen. And then any positives can reflect what the nurse or the intake staff actually really lays out a full screen for. So you can do double layer screening. There are quick screens. There are 2 question screens that you can do. And then only if they screen positive, you jump to the next screening level. You can absolutely incorporate those. Google, actually, if you now Google postpartum depression, comes up with the screen for postpartum depression. They do the EDPS. And so if you think that, you have any patients who might have depression but aren't going to tell you about it, put that Google link in your prenatal materials. They can get the same score on Google. And when they come up with a score over 10, Google says, hey, call your doc. You might be experiencing postpartum depression. And so reaching outside of the box and really reaching where patients are at can be a good thing. A lot of offices have moved towards doing a 2-step intake. So doing a nurse intake that's an hour long that all of the screens are gone over, and then having that first provider visit really to only talk about those screens that had pertinent positives on it, and to go more in depth and do your SBIRTs there. And so really it's whatever works best for your space. I think when you're talking about inpatient, right, it's hard, right? We're juggling 10 million things to do. The patient-centered approach always works well, right? Hey, are you concerned at all today about X, Y, Z? And then if you have a positive answer, say, okay, well, let me talk to you a little more about depression. I have this series of questions I'm going to ask you to determine how much of a trouble it is for you. And so you can kind of incorporate and triage that way. And then, when you're admitted your other 6 patients and you have time to go back and do the full assessments on the other ones, then go back and do those. And so just having some flexibility, but also just a plan.
Yeah, very helpful. One size doesn't fit all, right? It's situation, timing, circumstance. Sure. Thank you. Brandy, sorry to be the one asking all the questions, but I'm just thinking of things we've seen participants ask who might not be on the call today, and others might have the same question, but just maybe multitasking right now, as we know, many people are working today. I'm wondering, again, kind of thinking of the hospital setting, and you had mentioned about weekends specifically for like MAT and other treatments. That did come up from some of our hospitals, that they're struggling a little bit with thinking about process that might differ weekday versus weekend based on resources. And so I don't know if there's a solution to that. Like, what would a provider do? Especially a lot of our clinics, or I'm sorry, hospitals might be in rural or frontier regions, and resources are scarce as it is. But are there like hotlines to call? Are there things in place that you don't discharge the patient until there's a resource available? Or do you have any thoughts around that too? Because I have seen that this whole weekend. Mm-hmm. Different staffing models, different access to resources that we want to refer for treatment to aren't available. And what would someone do in that situation?
Yeah, this is one of those where this collaborative team approach is super important. Because if you have a pharmacist on board and on your team and in communication with them, you can discuss other options for a 2-day dispensing of a methadone dose, right? So that you can discharge them on a Friday, they can take a dose on Saturday, they can take a dose on Sunday, and then get intake on Monday. But you have to have a willing prescriber, and you have to have a willing dispenser. And so those are critically important pieces. We certainly saw people boarding over the weekend, right? So where they would stay Saturday, Sunday in the hospital the entire time, even when stable and didn't have a hospital need. Working with your ER colleagues, I've seen it where the ER has been the doser, So people come in essentially for a scheduled ER visit, right? To get their methadone dose in the morning, they're dosed, they go home, right? And so, but you have to think about it ahead of time, and you have to have the whole team on board. And so I think with these patients, we really have to think outside the box. Again, I think with the buprenorphine getting a little more relaxed in terms of prescribing, we're going to have more of those prescribers who are willing to do a 1 or 2 day prescription to get patients through the weekend. Methadone's still a little challenging, but I think as we reduce the stigma and the bias around this diagnosis and this disease, we're going to see people who are more willing to help for those 1 or 2 days. But it is setting things up and making sure that everybody's on board.
I love that, having a plan, right? And working with pharmacist team, ED. I know Katie brought that up on, previous coaching calls, is like engaging your emergency department, identifying providers that have that ability to prescribe or administer. So yeah, it's a team effort, like you said, collective, right? Work, and we're here to help for that. So hopefully when hospitals do have questions, if there's anything that the collaborative and we as support can do to identify resources, make connections, either in the hospital or in the community. A lot of our hospitals that are participating are working on that community connections and warm handoffs. So I think that, echoing what you said, like that's really important, kind of thinking through all of that in advance so we feel like we're prepared and have resources.
Yeah. And then I think you guys are going to get the slides, but I did include a bunch of slides at the end that go into a little bit of the multimodal treatments. So if you do have some of these processes working around blocks or tap blocks or things, they're in those slides as resources for you to just kind of quick reference. And then they are all in both our document and actually the anesthesia Colorado Cures document is also fantastic. So, I mean, they're all fantastic, but I found that one the most relevant.
Great. Any other questions from participants? All right, it looks like, as Katie mentioned, we'll get all of Brandy's slides out as well. It sounds like there's some additional resources there that we didn't go into depth to for today, but very helpful information, Brandy. That was awesome. So practical. And the other thing you mentioned that I'll just kind of put a question out to the audience, no need to answer immediately, but Brandy, you mentioned diversity training. And I'm curious, we had worked with March of Dimes, just kind of look at some bias in maternity care, and that's all the buzz with many organizations is, how are we supporting that work and helping people acknowledge bias and then, break it down and really address that in the care of our patients. And so I'd be curious, feel free to chat in if the hospital you work with or for or represent, a lot of you go to different hospitals or numerous hospitals, but I'm curious if hospitals are doing some sort of equity training or bias training. We as a collaborative would love to continue to work with partners to get funding to be able to offer that free of charge to all of our participants. And I've heard some rumbling. I know Denver Health was able to get some funding for that specific March of Dimes bias and maternity care training. So they've got some plans, but just, if you have thoughts or comments, either your hospital is doing this or isn't doing this, or would you like some resources? Let us know, because, the more we can do as a collaborative to help support you with education, resources, and tools at no cost, we'll try to work really hard for that. So loving that it's on people's minds, but wanting to also make sure that it's actually happening and that it's not a one and done, that we're really changing the culture and not just checking a box when it comes to training. Perfect. ACOG, ACS, AMA, NMA, all of the big orgs. Yeah, and I bet there are some online, some virtual courses, that sort of thing that are really, and it looks like MIC looking for some options. So again, think if there's anything CPCQC can do to help you identify those trainings, support you if try to get some funding if there's a cost, or direct you to some free of charge classes, let us know.
Yeah, and I actually have some great recommendations for those trainings. One thing we may do is there's a self-paced training that I believe the HRSA or the Office of Health Equity or Office of Minority Health has created. It's specifically about bias in maternity care, and it's free and self-paced. So I will send you all that resource. But one thing we're considering doing also for the collaborative is perhaps timing it so that we ask you all to do this self-paced training. It's 2 hours total, but again, self-paced. And then we could come together as a collaborative to discuss it. So that's in the works. We're thinking about doing that at our next learning session, which isn't until late October. But in the meantime, I'm happy to send that resource again. And of course, whenever I come across good ones, I'm sharing it with you all. But always feel free to reach out if you're looking for this, because I will direct you to the right places and give you pros and cons of different ones. And some are free, some are not. I have a good list of free ones. So yeah, if you're excited about that, we're excited to help you.
Yeah. And the other thing, I know we just have a few minutes before our Tough as a Mother video, but I also wanted to throw out, as y'all are thinking, hopefully some ideas are in your mind as we talk about small tests of change, right? Like not afraid of failure, but really trying something and seeing if it works. The other thing I would mention, the one element that is critical that I cannot say enough is including patients in this work so that we can get input. And as many of you know, we have an expert faculty group that involves folks with lived experience, specifically in the substance use disorder and recovery. And they are really helpful at providing just, kind of ideas about how to have these conversations, what questions to ask, how to make this meaningful, really make it a conversational screening, and really just insightful in that they're fearful. We talk about that a lot. There's a lot of stigma and how we overcome that. And so I would encourage you as well in your hospital settings to think about how to engage patients in this work. And so like I mentioned, it could be that one time, one patient, asking them or, informing them why we're doing this and why it's important. And if they would be okay with, giving you some feedback about the process and how they felt and the questions and that sort of thing, because the patient perspective is so important. So having patient partners will be critical for really implementing a solution in your unit that makes sense for everybody. So I would encourage you, and if you need help in that area, CPCQC was just fortunate enough to receive a grant fund to develop a family integration program. And so we're working on some formal training for patient partners who may want to participate, and then we would integrate them in all levels of our organization and our quality improvement work. So ultimately we'd have some resources for you to leverage, some patient partners. But I would advise you to, have those conversations at your hospital as well. Is, do you have a family engagement group? Do you have a strategy? And how could you start with just one patient, getting their input, and then really embedding that into the work that you're doing, because that patient partner is so important in this work. So reach out to us if you'd like some help in that area. Share resources if you have. I know people from SCL Health. I've seen the parent NICU group, and they are phenomenal. And parents do rounds, and they actually are the ones giving updates on their infants' progress and medical condition. And so it's really, really amazing, the work that's happening. So I know it's out there. I know that y'all are doing it. So share so others can learn from you, and you may need help. So reach out and let us know how we can support your patient partner engagement in this project as well.
I also wanted to ask, I know we've talked before about, having one of your action items be to connect with your ED departments or just other areas of the hospital to find out who in your hospital is that resource that typically does MAT inductions in the hospital. So I'm curious to hear from you all. Have any of you connected with those people in your hospital who can start MAT in the hospital? Have you had challenges connecting with them? Has anyone initiated MAT during an L&D patient stay, and how did that go and what was your process? We'd just love to hear more about how that is going in terms of connecting with people in your hospital who already have the experience of MAT induction. And if no one has connected with their EDs or anyone else, we want to hear that too. We want to hear why. Is it a capacity issue? Like what is the barrier there to connect with people in the hospital who already are initiating MAT? Bueller.
We may start giving out gift cards for participation.
So that's the carrot, or the stick is we just start randomly calling on you.
No, we don't do stick with QI. Positive reinforcement.
Hey there, Katie and Jamie, it's Lisa Becker, and I want to give a shout out to Allison and Kaylin, who I was pleasantly surprised that when I threw out MAT training to our obstetrics group, 10 people jumped in. And so we are arranging a training with Kaylin's expertise. And so that will provide a provider at PSL, at Swedish, at Aurora, and also in one of our clinics to be able to initiate and continue MAT. So I'm super thrilled and grateful to all of the people involved with that.
That's awesome. Congrats. That will make a difference. I love it. Awesome. You can hear it.
And there are also some upcoming opportunities for other people to join. I sent this in the newsletter, but I'll find it to share again. But on, I think, July 14th, there will be a provider MAT training. It's only a couple of hours, and it's for anyone who wants to learn more about prescribe or providing MAT, especially in light of the fact that the DEA waivers are no longer required. And there will be both a virtual and in-person option. The in-person option is in Colorado Springs, and the virtual option is online. But I will be sure to share that with you all again. And there's also, so ACOG and ASAM have a co-developed waiver training, and they put out resources too. And I believe they're hosting some sort of event at the end of July or in August that I will share again, just so you all can, get comfortable with initiating MAT on your units and enjoy the perks of not needing the DEA waiver. So with that, we will move on to the next thing. Let me get all of my decks in order. Ducks in a row, decks in a row also. And get started. So I'm just going to share this really quickly. Wait, let me make this full screen for you. Present. Okay. So I'm going to have Callan Thornton come off mute and speak next. She's going to give us a little introduction, and then we're going to play you a video from my screen.
Awesome. Well, hi, everybody. My name's Callan Thornton. I recognize many of your names and know many of you, and I'm excited to connect with those of you I haven't had the opportunity to meet yet. I work with the Office of Behavioral Health. I'm called the Manager of Gender Responsive Services, which really for all intents and purposes means that I work with pregnant and parenting, work on efforts to expand kind of the service continuum for pregnant and parenting people impacted by maternal behavioral health issues. I'm really excited to get to talk about the Tough as a Mother campaign today. I don't know how many of you have already heard of us, but we are a statewide public awareness campaign, and our mission is kind of twofold. We exist to decrease stigma around maternal substance use disorders and to help connect pregnant and parenting moms to the support and treatment that they deserve. We just celebrated our 1-year birthday in May. We launched over Mother's Day of last year. And this first year has been amazing. There's a couple links that I'm going to pop into the chat as the video is going on so that you can connect to our website and our statewide gender responsive treatment map. So I oftentimes hear from providers, that we don't know where to refer when there's a positive screen, or how do we know it's a good referral. So there are a network of substance use disorder treatment providers across Colorado that have a special designation from the Office of Behavioral Health that they offer gender responsive services, meaning that they are able to offer some form of treatment in a women only environment, that their clinicians specialize in trauma responsive care and kind of know how to work with the unique needs of pregnant and parenting moms with substance use disorder. So we have a website, we have a quarterly newsletter, social media following with a lot of parents who are in recovery or pursuing recovery. So I want to make sure that you get connected to all those resources to be able to share with patients that you might be working with. This provider education video is just an overview of kind of what is gender responsive services. So you'll see me on there talking about what that means and how to kind of adopt a gender responsive framework in your interactions with patients. And then Christy Jordan, who you see there at Signal Behavioral Health, is going to give an overview of the Tough as a Mother campaign. And then afterward, I will be here to answer questions and to plug a couple more campaign related resources that are available right away were you to want some of our materials in your unique settings. So with that, Katie, will you get us started?
Yes, I will. I'm going to stop sharing and then reshare just to open it in YouTube, make sure you all can hear it and see it. Okay, great. Share screen. Okay.
I remember it like it was yesterday. I was 55 miles away from home, completely intoxicated, and had my children in the car. No mama wants to admit that. The choices I had were to either drive myself and get myself some treatment, or I could to drive myself home with my kids in the car. In a split-second decision, I made the choice to drive myself to treatment.
My name is Callan Thornton, and I'm the manager of Gender Responsive Services at the Office of Behavioral Health. I want to share with you today about gender responsive services and why moms with substance use disorders really need us to take a special approach with them. I'm also really excited to talk to you about the Tough as a Mother campaign, which is our state's public awareness campaign for moms who are struggling with substance use. This video and the Tough as a Mother campaign are intended to help you understand the unique challenges that moms with substance use disorder face and to help you support them in their journey toward recovery.
They're carrying an enormous weight on their shoulders, and they're often carrying it alone. Many are living in survival mode, facing ongoing stressors that don't let up. Sometimes, for a whole host of reasons, moms end up using substances to cope. Mothers don't need us to judge what they're carrying. or pretend it doesn't exist. We need to understand the burden on their shoulders, help lighten their load, and meet their needs as parents and as women more specifically. Stigma is one of the greatest barriers to moms seeking treatment, and it's often perpetuated by providers and her community. Societal stigma and stereotypes of women who abuse substances tend to be greater than the stigma toward men, which leads to women being underdiagnosed with substance abuse disorder, and it makes women less willing to come forward and ask for support. Stigma includes negative beliefs, attitudes, and characterizations about moms who are struggling, and the misconception that substance use disorder is a choice. In reality, it's a medical and behavioral health condition, not a moral shortcoming. As a provider, here's how you can disarm stigma. Normalize talking about substance use. Let her know that many moms struggle with substance use, and you're on her team and available to support her. You can't look at someone and guess if they struggle with substance use. Adopt universal self-report substance use and mental health screening. Use person-first language and terms such as moms with a substance use disorder versus a drug abuser or addict. Use recurrence of use versus relapse. View addiction as a chronic disease, not as a moral shortcoming. Be transparent about testing and reporting requirements and correct misinformation. And consider peer support partnerships and hires, someone who has been through it and can provide non-judgmental support.
So when I'm talking about gender responsive services, I'm really talking about services that are designed for pregnant, postpartum, and parenting women. And these services have to be designed around the realities that shape women's lives. Some of those realities include factors like her unique biology, the caretaking role that she's more likely to be playing in her family and in her community, the trauma history that she is more likely than her male counterparts to have, the mental health issues that she's subsequently likely struggling with, the economic hardships that she is more likely to be facing, which cause barriers to treatment. It's also really central to women's lives to conceptualize them as a part of their relationships, as a relationship is oftentimes the central organizing factor of a woman's life. So that could include relationship with kids, with family, with significant others, with parents.
One of the things you should know is that stress and hardships for these moms are multidimensional. Let's look at Maria's story. She's a good example of why biological, cognitive, behavioral, and psychological dimensions of a mom's substance use and abuse should be framed in their socioeconomic contexts, including, but are not limited to, employment, educational status, transportation, childcare, housing, literacy levels, and income.
So part of being culturally competent is remembering that there are cultural competencies that are really specific to women, and that cultural expectations and gender norms vary greatly across different cultures. There is huge diversity among pregnant, postpartum, and parenting women, and they have many different identities intersecting at different points, all of which may influence this mom's attitudes toward the healthcare system, the degree to which she trusts the healthcare system, her personal beliefs, as well as identity group beliefs around help-seeking behavior and attitudes around self-disclosure. Representation is super important. This means that the staff in your organization might actually look like the clients that they're serving, that they might speak the same language as the clients that they're serving, that they have some of the same cultural understanding, live in the same communities as the clients that they're serving.
It's so essential to universally screen for substance use disorder because female patients are more likely to experience physical issues more quickly. The consequences of her use are going to stack up faster, and time is important. Women's bodies metabolize substances differently. They become dependent on substances more quickly, and their bodies are harmed more quickly by substance use, including liver disease and other organ damage, cardiac-related conditions, reproductive consequences, cognitive and other neurological effects, breast and other cancers, and greater susceptibility of infectious diseases including HIV, AIDS, and hepatitis C. It's also important to know that suicide and accidental overdose are leading causes of maternal mortality, and that a mom is at high risk during the first year postpartum.
For a while, I stayed in a woman's shelter and found myself in relationship after relationship that were always with men that were relatively abusive. And then I met a man who was, who drank quite a bit. Towards the end of our relationship, I started drinking with him. And like that, I was in this mountain of emotion and trauma, and drinking made me forget. Through this process, I learned that who I am is not a product of my mistakes and every time I fell down. That's not who I am. And that's what I want everyone to feel.
Women are significantly influenced by the relationships in their lives. It's really important to not only find out what's going on with her and make sure that she gets the support that she needs, but also to find out what's going on with the people that are most important to her and making sure that they get the support that they need as well. A relational approach is really important when it comes to assessing and treating for substance use disorders. A relational approach really views substance use as disconnection and views recovery from substance use disorder as repairing connection. So repairing connection to one's children, to family, to friends, to oneself, one's own belief system. A family-focused perspective means that not only are we providing services to mom, but that we're also providing any needed prevention and treatment services to the people that are most important to her, the people that she defines as her family. And in Colorado, we're so lucky that there's wonderful treatment options where moms can go to treatment and kids can come with them and receive the support they need as well. So moms don't have to choose between parenting or recovery. They can do both.
Grandchildren, parents, and other dependents. These roles may heavily influence the woman's willingness to seek help for substance abuse, and also may interfere with her ability to fully engage in the treatment process or to follow through with treatment recommendations.
Many women in pregnancy are highly motivated for treatment and welcome the resources and ideas for improving their health during pregnancy and beyond.
When I was in the doctor's office, I was nervous about them taking my baby away from me when I had her.
Important for us to know the laws and protections around substance use for pregnant women. For example, there's laws that exist in Colorado that should a woman have a positive urine toxicology test in pregnancy or admit to substance use in pregnancy, that information cannot be used to bring a charge against her or incriminate her.
Trauma severely disrupts a person's sense of themselves as safe. And so part of adopting a trauma-informed approach is for us to make sure that we're creating a safe, transparent, trustworthy environment for women to recover in, where they feel empowered to make choices. And all of these things impact her substance use disorder recovery. So it's essential when we're thinking about treatment that you have substance use disorder on one hand and trauma treatment on the other hand. They have to go side by side.
I find that when I really listen to our patient stories and identify the substance use as the end result of a whole lifetime of experiences that have led a woman to that point, I have not only increased understanding of her needs and what will be best for her healthcare, but also increased empathy and compassion for a patient that sometimes at first glance is a difficult patient to care for.
A strengths-based approach means that we are recognizing and talking to moms about their strengths. She hasn't gotten this far without having a lot of strengths. Part of our culture for women is that we shrug off compliments. We don't like to take the credit. What we can do as providers to counteract this is to help a mom explore her strengths, name those strengths explicitly, and build upon them.
I understand that doctors are busy, but it'd be nice to have one that would have had a heart-to-heart with me and asked me more in-depth questions about my alcoholism and how I was planning on dealing with it, or if there was any way they could help me deal with it instead of just yes/no questions and checking them off.
So patients are looking for providers like you and me to, first of all, open the conversation and create a safe space to discuss what's going on in their lives, whether that's substance use, mental health concerns, or other concerns. But by bringing up the topic of substance use ourselves, it allows our patient to engage and gives the message that this is a safe place to have a conversation.
So in summary, the 3 things that I hope you remember from this video are that adopting a gender-responsive framework and approach can transform the way that you work with moms. Secondly, keeping that trauma-informed perspective in mind. Approach every mom like she has a trauma history so that she can experience herself and her relationship with you as one that helps her to be in control, feeling safe, and empowered to make choices. Finally, I want to say that we all got into this field because we care about people. It's essential to remember that healthy moms make healthy families. So if we want kids and families to thrive, investing in their moms is so important. And the last thing I'll say is that even if mom isn't ready for treatment today, that's okay. It's the relationship that is so important. If you establish yourself as somebody that she can trust, somebody that she can talk to, somebody who's not judging her, you may be the person that when she's ready, she comes to and can ask for support.
And we're just trying to survive. It's a disease. That addiction is a disease. And like I say, if you don't live it and you've never gone through it or you've never seen a family member live that, you won't understand it. You won't. And you could be a doctor and you could specialize in this your whole life and still not know. If I could give any advice to any doctor out there, just come with respect, and because we're scared. We're scared.
Hi, I'm Christy Jordan with Signal. I'm excited to share some resources with you about our statewide public awareness campaign, Tough as a Mother. Tough as a Mother launched in May of 2020, and it is to help Colorado women with dependent children get connected to substance use disorder treatment services in their communities. Although there have been efforts to outreach to pregnant mothers in Colorado and nationally, there's been little efforts done with women with dependent children. Tough as a Mother is a collaborative initiative through the state's managed service organizations and the Colorado Office of Behavioral Health. The campaign is intended to create awareness for moms who need treatment, that it's possible and that it is available. And it is also for providers like you to give you the marketing tools and the outreach resources that you need to reach these women who need this level of care. Through a cohesive and collaborative approach, we can get more mothers started on their journey to recovery. We built this campaign with specific goals for moms. We know that she can often feel isolated and judged. So this campaign is to meet her with compassion and empathy. Here are some examples of the messaging we've developed to combat the social and psychological barriers our moms face and encourage her to start her journey to recovery. Our key messages on marketing materials include, we recognize that being a mom is tough, but so are you. If you're using alcohol or other drugs to cope with stress, you're not alone. Support is available. It is okay to admit you are struggling. Here's a phone, text, and web option for connecting to help. Our messaging combats social and psychological barriers that moms face and encourages her to start on her journey to recovery. Our website is also a great tool for you to use. MSOs know all of the providers in their regions and can help connect mothers to an individualized and customized plan. Most importantly for you, there is a resource page on the website specifically for providers. Here, we outlay the best approach to making a high-quality referral, one of the most critical junctions in her decision to seek support. We also list other valued partners here that support the campaign with tools and resources.
We have built a robust provider map as a resource to moms. The first point of contact encourages her to create a partnership with a managed service organization, or MSO, in her area to learn about treatment options. MSOs know of all the providers in their regions and can help connect mothers to an individualized and customized plan. Mothers can navigate the map by city or county. As she selects an option, the MSO in her region populates, helping her see how to take the first step to seeking services. Other important components of the site include resource pages for mothers on other partners that provide critical supports for recovery, like childcare, transportation, and support groups. Videos of moms like you. Women seeing other women in recovery is one of the most powerful and motivating tools we can share. And all of our resources are translated into Spanish. Supporting the campaign is easy. There are several ways you can start today by promoting our campaign and strengthening your community outreach strategies. Distribute this webinar to other professionals or partners on your team. Display materials at your office or location. Distribute materials to community partners and businesses. Promote the campaign on your website, digital, and social media. Distribute our press release and radio PSA to local media. Promote the campaign to local elected officials and other local influencers.
We appreciate the work that you do every day to support Colorado mothers who struggle with a substance use disorder. Together, we can reach more women to get the treatment that they need to be the toughest mothers possible.
If you have questions, need assistance, or are seeking a resource not found on our website, please contact us at outreach@toughasamother.org. For additional information on gender-responsive services, contact Callan Thornton at 303-827-5861 or email callan.thornton@state.co.us.
Why did I decide to go to treatment? I was at the point in my life where I had two choices: get better or die. My organs were failing. I had lost almost everything. And even my kids were living with family because I was too sick to take care of them. I knew that I needed to change and I needed help to do that. Once I made up my mind to get better, I reached out for help. I reached out and I found people who would help hold me accountable without judging me and giving me a place where I could find safety. Knowing that I still have these people in my life today is what helps keep me in recovery and keeps me able to live life the way that I want to.
Thank you for taking the time to watch that. And I just want to open it up for any comments or questions. I popped a couple of links into the chat of some of our, at least some of my favorite resources that we have so far. What are your guys' initial impressions? Do you think this campaign might be useful to you, and how could we make it more useful to you?
Callan, I love that there's a provider resource section, right? So we keep hearing folks who don't feel confident they know where resources are or information that they could share with their patients. So I think that's awesome, right? Like there's a place for providers specifically to go and get more information. I see Lisa's chatted in, loves this. how can they order brochures? So could you talk more about how people can get some of the actual physical information in the hands of their patients?
Absolutely. So I just popped a link in the chat. This is on the website. So when you visit the website and click on the tab that says for providers, there's a little drop-down menu, and one of those options is campaign resources. And we have a bunch of what we call crisis line cards, which are, little cards that are the size, you could have it in a basket in an office, and they're small enough that a mom could kind of discreetly fold one up and pop it in her shoe if she didn't feel comfortable with, the people she was with, or, having the provider actually hand her resources related to substance use. We have posters, rack cards, what we call our family first cards, which are really trying to speak to some of mom's fears about child welfare involvement, of kind of, letting a mom know that Tough as a Mother isn't affiliated with child welfare, and that a mom can anonymously, access the website and look at all the resources that are available in her own timing and own pace. So what we really hoped with this campaign is, so we have all the resources on the website that, at least at the hospital I used to work at, we had a fancy color printer, and you would be able to print these as many as you want to, and use them in whatever way you like. I'll also say that we do have a surplus right now of some of the materials that are already printed. So specifically, I think the family first cards, we do still have some rack cards. So if you are interested in having me send you some of those, we usually send them out in batches of about 500. So feel free to outreach me directly if printing would be a barrier for you at your setting, and I will happily coordinate getting some of these materials to you. We also have social media posts that you are welcome to use on your organization's social media accounts. Depending on the type of marketing that you do in your organization, we also have kind of sample press releases if you wanted to, write something about this in a hospital newsletter. We have radio scripts, so all sorts of free sort of marketing and media materials at your fingertips.
Awesome. And so like Callan said, she chatted in some of those links. Lisa's saying printer is not friendly. So she's got her address in there, Callan. And I would echo that. If Callan and her team, if y'all run out and printing is a barrier, just let us know. We can certainly try to find some funding for raising awareness and other things that I know CPCQC has some great partners to work with on and get you that. I know whatever your situation, your hospital, printing is a nightmare, budgets are an issue, don't let that be a barrier. Just let Callan or, info at cpcqc.org and we'll send you that. And Callan's got, Lisa, your address now. Awesome. Some great feedback, Callan. Others like Mick saying you're going to share it with providers today. And yeah, Lisa, awesome. Thanks. I think, that's the beauty of the collaborative, right? It feels like everybody's here to support each other, whether that be technical assistance, information, resource sharing, financial assistance. Let's all do this together. The more information that we can get to our providers and our patients, the better off we all are. So if you have a barrier, don't be shy. Let us know what it is.
The last thing I wanted to offer is, I know at the hospital I used to work at, we would have, grand rounds or a monthly OB meeting. So if it would be helpful in your setting to have me or one of the Tough as a Mother team come and present directly to your organization about Tough as a Mother or any of our other sort of gender responsive treatment services, that's another thing you're welcome to reach out to me about, and I'm happy to do that.
All right, any last questions or comments regarding Tough as a Mother resources, issues, needs, barriers?
And I'll be sending out all of the links that Callan shared in the newsletter after the event.
Thanks, Katie. Well, thanks again, Callan. I work so closely with you and have never been able to sit and watch the video in its entirety. So you do a great job. And we saw our friend Kaylin Klee there and others. So and again, I think the patients as partner philosophy and listening and hearing their experiences is really important in guiding our work. So great video, and thanks for sharing today.
My pleasure. Thanks so much for having me.
All right, we'll see if I can facilitate sharing my screen again as we move into our next session, which is some more team time. This time we're doing things a little different. You've obviously noticed that already. Instead of breaking out into specific hospital teams, we want to encourage conversation, collaboration, and just like really sharing together with all of you, because this is really, you know, the work of the collaborative is learning together, commiserating, you know, talking through challenges, working through these together, thinking of things that, you know, we might think is just unique in your patient population, our physical location, how our hospital's set up, or where we might be located. And it's probably not, you know, something, we all are unique in certain ways, but it's probably, if you're experiencing it, somebody else most likely as well. And so sharing that experience is how we'll learn together and work through those. So for today, we've had one hospital volunteer to share their experience to date. And again, just reminding people that we can't go from 0 to 60. So we don't expect any of you to say, oh yes, you know, we have 75% like screening already happening, anxiety, depression, substance use. This is a work in progress, and we're testing change, and we're doing that in small tests, right? And so what we wanted to do today is have Montrose Memorial Hospital, and I believe Jonna Hogue, the LPN CLC Lactation Program Coordinator, is here with us today. Jonna's going to share just, you know, some of the things they're trying, what's working, what's not working, and where they are in their journey. And hopefully that'll give you some ideas, and hopefully you'll have some questions or conversation and some things that might resonate with you. Like I said, I was able to see your input, your questions about your experience to date, and there's definitely a lot of themes. And so you'll hear some of those from Jonna and Montrose Memorial Hospital, and hopefully you'll feel comfortable having some conversations around that with the group today. Jonna, do you have slides you'd like to share, or just gonna verbally, would you like me to transfer to you, or just have you?
Well, I was hoping to use our slides, but I think we're just going to talk. My video is not working on my computer, and I was hoping Courtney would be back.
That works.
One of the biggest reasons is why we started this, and it was to help our substance use disorder patients and our patients with depression get the resources and the treatment they needed. My number one challenge was just finding the resources. There actually was resources on the Western Slope we weren't aware of. And so you all have definitely helped us compile a treatment and resource list for our providers and our patients. We also have finally decided on a TABS tool to screen our patients in the office before they come to the hospital. And the reason we went with our TABS tool, it covers pretty much everything: alcohol, cigarettes, marijuana, cocaine, of course, opiates, and prescription drugs. Courtney's here now also. Do you want to add anything else about our challenges?
Sorry, guys. I am putting out a couple fires this
morning.
All right,
you're working.
So I'm going to let you just do it because I'm coming in the middle to this. So go ahead.
Okay. So those were the biggest challenges we had at the beginning. And the other thing is I don't think we realized how much time it was going to take to gather everything that we needed to find the different tools, the resources that were available. But we have found quite a few resources, which we're really happy about. The other thing was scheduling meetings with our OBGYNs, the pediatricians, our family practice docs, trying to find the time in the same place to get these meetings scheduled and just find all the different resources for them.
Yeah. Scheduling's always a challenge, right, Jonna?
Yes, it is.
But I love that idea. And I think that's so critical is, cross sector, multi-specialty, right? Like engaging the different providers. I know, having worked with your hospital for a number of years now in the collaborative, that there is an engagement. And when you all set out to do quality improvement work, everybody comes to the table, and, and I things where your, CEO is there. Oops, sorry, I clicked the button and advanced all the slides. But been in meetings, so there's executive leadership buy-in, there's, like you said, family medicine, OB, everybody's at the table. And you say you struggle, right, in terms of like scheduling that, but how do you think you've been successful? Because in my experience working with y'all, like, it's working. They are coming to the table. Any ideas, was it free lunch? Because we all know that, doctors show up when food's there, right? Or if you do it like really early before rounds start, or if you do it at a certain time. But like, do you have any advice of like how you're actually scheduling the challenge, but how are you actually even just getting them there and getting them to participate?
Sure. So this is Courtney, and we are fortunate, again, like you said, we are a rural hospital, so we're smaller. But we do have a monthly OB committee meeting where we bring all our peds, or not all, we bring 2 representatives from our pediatric group, our entire OB team, anesthesia to the table, as well as senior leaders and quality. And it's at these meetings that we're able to kind of bring this stuff together and make some decisions. I will tell you in the beginning, though, for us, it's easier to kind of put everything together, right? Because when it comes down to this, you're trying to get buy-in from physicians and everyone else. So I didn't want to go to everyone as a group until I started planting the seed individually with people. So like Jonna had mentioned before, our biggest challenge for us on the Western Slope was trying to find our resources. And so by the time that, thank goodness for you guys, and embarrassingly enough for us, just not realizing how much we had around us, but Grand Junction, St. Mary's was super helpful. You guys were helpful. We got a bunch of social worker, caseworkers involved that gave us their resources. And so by the time we got everything packaged together, and then we kind of laid out a simple PowerPoint that was just a couple of slides that talked about what we're wanting to do, why we're wanting to do it, and what does that mean specifically for them? Because at the end of the day, doctors care about how it's going to affect them and how much work are they going to have to do, right? And so once we got all of that packaged together, we basically, in a way, did our sales pitch. And so we met individually with our pediatric doc, who's the head of his group, and then we met with our OB group, and we got buy-in individually from them. Then we brought the whole package to the OB committee where everyone could kind of chat about what does this look like for everyone as a team, and how do we move forward? What are the next steps? And that's kind of basically where we are right now. We've got everyone's buy-in, we brought it to the team. So now Jonna and I are trying to work on the finer details, like our order sets and education material for the staff, so how we roll it out to the staff, and then our EMR. That's the big challenge for us.
Yeah, great. You hit on a number of things. I know you were running around today and didn't get to see all, but I think some of the key things, for the group to think about that we talked through, and kind of the psychology of change, is like the why, right? And we all kind of come together that, screening is important so we can identify issues, refer for treatment, right? But finding the what's in it for me, the with them, going back to, I don't know, maybe that dates me, but that used to be like a thing, right? The what's in it for me. And that's how you can find what's relatable to each individual. And like you said, you have a small hospital, so I'm sure many folks on this call feel like, well, we have 50 OB docs, and so how do I find the what's in it for me for all 50? But we don't need to, right? But finding key early adopters, people who are going to help be your champions, people that can get their peers on board. So finding your physician champions, finding your senior leaders, finding their with them, what's in it for them, bringing that together, it sounds like you got that right, and that it kind of is a sales pitch, right? Because not everybody always starts on the same page, and there's a little bit of, trying to convince people, or when you show the why, then it can resonate with them. So all great things in terms of like, how do we bring people to the same place and want the desire to change? And then how do we put the tools in place to make that happen? So sounds like you said, you've been doing this for a few years and have some experience in quality improvement.
Yeah, no, and you hit the nail on the head. And really, even if I were in a bigger hospital, everyone knows who your key players are, right? And who are open to change, and who has the respect or are leaders of change that the other physicians will kind of follow in their footsteps. And so if you can identify a few of those people and just start planting seeds, that is a starter point while you're getting all your stuff together. And then if you can schedule individual meetings with a few of those key players, and then figure out whatever your facility does, if you guys have one big meeting, or like you said, we do ours at lunch because we do give them lunch, and that's why everybody wants to come, because everybody likes free food. But you still identifying those people who are leaders of change and open to it, and then who the other docs look up to and are willing to follow in their footsteps. I think it's a big deal.
Yeah, absolutely. Do you mind sharing, Johnny, you mentioned the TAPS tool. Does everyone, well, I guess that'd be a bad question. Does everyone on the call know what that means? So maybe we want to just, Katie, type out in the chat the TAPS tool, and if folks aren't familiar or something, we could certainly get a Google link to. But it sounds like there was some consideration about what tool to use, and time was a consideration, and we've seen that from pretty much every hospital, that staff time is a challenge when we think about all the questions we want to ask in this conversational screening concept. So would you be comfortable telling us a little bit more about maybe why you selected that tool, or what that process looks like, what you're going to use in your area?
So it's Court again. I'm going to help John out with this. So she's done a lot of great work, a lot of research on this. And we've looked at several different tools, like you mentioned. The reason that we kind of looked at the TAPS tool is because it's just an all-inclusive tool all the way around. It is larger. However, it does drill down into tobacco use, alcohol use, prescription medication misuse, and then like your normal street drugs, your illicit substances. So instead of doing 4 different screening tools that cover alcohol and medication and narcotic use, and this one is just all inclusive, and it helps you identify. Again, when we did this, we kind of made this program even a little bigger, and I know that we're looking at kind of expanding what this looks like instead of just opioids, but this will help us identify someone else who maybe has an alcohol problem, and we need to get them resources for their alcohol use.
Wonderful. I'm going to pause to see if there's any questions from the group about the tool itself, some of the important things you talked about, like planting the seed, picking your champions, getting buy-in, finding out, what drives people who have to participate and should want to participate in this change. But I'll open it up for any questions from other hospitals. Does this resonate with you? Does this sound familiar? Are these tools you're considering? How are you engaging your physicians and nurse and executive leaders? And don't be shy. Oh, it looks like, Lisa, y'all are working with TAPS as well, using TAPS, and it works well. So it sounds like a fairly common tool and useful. Great, thanks for the input.
Jamie, while everybody's kind of typing, we do have a question to counterback. In Jana's research, because also we're looking at, not just implementing this in the clinic, like with the TAPS tool, we also will be putting this in our OB clinic to identify them there. But if we do have someone that comes in and delivers a baby who we are having to do NAS scoring on. We've seen people using both methadone and morphine, or morphine and clonidine. Does anyone on this call have preferences one way or the other, or any recommendations in your guys' research or actually putting it into use?
I'm pausing. I'm trying to see. I know we lost some of our clinical speakers from today that have knowledge in this area, but feel free if there are others that could chime in to Courtney's question. Courtney, if there are no takers, we can take this as a follow-up. Certainly, Kaylin or others might be able to make some recommendations there, or just talk about their experience. I know some of them weren't able to stay for the whole call.
That sounds great. Thank you.
And Jamie, I was wondering, do you know if there's any funding for the EMR?
Yeah, great question, Jonna. And I know we were kind of looking into this because it sounds like there are a number of hospitals that ideally would want to get this into the EMR, get a lot of the screening tools into the EMR, and are struggling with that either in terms of like the time to do it or the cost to do it. And so, you know, we're definitely putting our feelers out at CPCQC for funding that could be available federally or locally to support in this work. I know, I want to say, Jonna, are you guys on, is it Meditech or GE? One, I think both, but for different parts of the documentation, right?
GE and eClinicalWorks, actually.
eClinicalWorks, okay. Yeah, so we've got this on our list of, you know, reaching out to partners to see if there's any funding available for this type of thing for hospitals, because we recognize it seems to be a barrier for a number of hospitals from what we're hearing. I don't know an answer yet.
Well, thank you. And Jamie, one of the things I wanted to add is the success we've had, just getting everyone on the same page, everyone buying into this, and our new relationships we've made with everyone.
Jonna, and yeah, it sounds like, I know talking with you all in your one-on-one coaching call, just recognizing that there are community partners that exist in your region, right? And being able to connect to them. And you were doing some introductory meet and greets, and you know that really helps facilitate a warm handoff when something's identified. So have you been doing that on your own, just sharing for other hospitals, like your team, small but mighty? Have y'all just been reaching out and saying, hi, here's who we are, here's what we want to do, can we set up a call with you?
Yes, we have, Jamie, and it's been really nice because we've used Zoom a couple of times, but within the next month, we have some resources that are going to meet with our OBGYN doctors also.
Great, great. Yeah, it sounds like, sorry, go ahead.
Sorry.
No, you're fine.
I know that at SCL Health, we're working at with the maternal mental health toolkit. And so we're moving from the TAPS tool to the SBIRT tool. And one of the portions of that is actually looking at all of the resources here in Western Colorado. So once we line out what that looks like, I'm happy to share that with the group. And I'm actually interested to see what you guys have already done. So if you have that, will you please just shoot it over to me?
Yeah, Rainey, Jonna, actually, we've spent the last 2 months putting together a whole entire packet and list of resources, so she can send that over to you.
That's perfect. Thank you.
Rainey, can I ask you, why did you guys switch from the TAPS to the SBIRT? And I asked, we looked at it. Our ER is currently doing SBIRT, but we just didn't find it all inclusive. So I'm curious how come you guys are switching?
It's actually not my choice, and it's not Dr. Jackman's choice. We have an addiction specialist here, Dr. Jackman, and he's actually the lead. He's the cheerleader for the TAPS tool, but when it went to system, we have 8 other hospitals, at system level. At that point, they felt like that the SBIRT tool was more valuable and covered more information than the TAPS tool did.
Okay, wonderful. Thank you. That helps.
Any other hospitals still trying to decide what tool? Does this resonate? TAPS, SBIRT? Anyone having that same conversation now with your partner hospitals or leadership? I know, Mick, you said you're still trying to figure it out. So some of you may be still in that place, right? Just trying to figure out and assess what's out there. Right. I do want to mention, we're excited at CPCQC. I think Katie had emailed previously to have an intern that will be with us through spring of next year. And she's been working with Katie to figure out how we can support you all in community resource mapping. And so we know it's a big undertaking and it takes tons of phone calls and meetings and, trying to collect all of the resources in your region or even that might be accessible virtually to your providers and to your patients. So we want to help with that and are here to help with that. So if you're having challenges or if you feel like you're spending a tremendous amount of time on that and could use some assistance, Elena is, just started really getting up to speed, but has proved to be very helpful right away and just diving right into the deep end and helping our team out. So please let us know. Again, if you're having challenges, if you have identified a barrier, don't hesitate to let our team know. Like Jonna mentioned, we may not have funding for something, but we can put some feelers out with some of our partners and see what's available. We have resources and want to help you help make this as easy as possible so that you feel like you have got the information, can easily reference it and can share with your patients and your staff. And I see, Christina, you mentioned that you're trying to get funding to utilize the 4P screening tool. So I'm hearing, consistently there, right? Looking for funding, looking for resources. It's a lot of work and quality improvement is, and it will take time. So don't forget, small tests of change, one thing at a time, manageable, one patient, one provider, one day, 1 week. Test it out. Don't be afraid to fail, right? This might be the tool, try it, see if it works. And maybe that's part of your assessment is we're torn between the SBIRT and the TAPS. So let's have a provider who's a champion, give it a try on a patient when timing allows, get some feedback from the provider and the patient and see what worked well or what didn't or what you might have missed. Right? So don't be afraid. Don't be set on being perfect and going from 0 to 60. Test it out. See if it works. See if it fails. Document why. Document things you might modify going forward. And that will help you learn and it will help you continue to get buy-in from your providers, from your patients, from all of your partners in succeeding. So there is no true failure in this, right? You're trying, you've got tools, you've got information and resources now, and we'll continue to make incremental improvements. All right, and Katie popped in Elena's information. You will all get to meet her. and also let us know what's helpful in terms of seeing how you're doing. We've been diving into the reports. And again, we don't want to go from 0 to 60. So we're not really looking at like who's implemented a tool and who hasn't. That won't be the measure of our success anytime soon. So we're going to start looking at some control charts and some other ways to graphically represent your progress over time. And we can look at that together, like try a tool, see if it's working. Let's document, let's look back at the data. When you implemented that, did you see improvements? Did you see more screening happening? What did you identify when you were screening? Were you able to refer for treatment? And so we'll help you kind of, slice and dice that data a bunch of different ways. And your input is always valuable as well on what you're actually looking at every month because we want it to be helpful to you. It doesn't matter if it looks pretty on a graph for anybody else. So again, don't be afraid to test these changes, small incremental changes. Don't be afraid to fail and don't be afraid to ask for help when you identify barriers and share your successes because others are probably asking the same questions and really trying to figure out some of the same answers that some of you might have already moved on to. I know we're supposed to wrap up. I just want to make sure everyone's had a chance to ask questions. Jonna and Courtney, any last minute ideas or pearls of wisdom to share, or pains that you're still encountering?
No, we just want to say thank you, Jamie, to you and your team. You all have been fantastic in helping us. This definitely has taken us a little longer than we had hoped, but it's a big project and a lot of different units involved. I would say our biggest challenge right now is working with vendors to get the funding and get this tool implemented in. That's really our only holdup at this point. But if anyone needs any help, John is going to send our whole list that everyone has kind of collaboratively worked together to get resources. She'll email to Rainey, but she'll also email to you and to Elena so that you guys also have what we have in case we have something you didn't. And if anyone else needs any help with anything, don't hesitate to reach out to Jonna or I ourselves as well.
Awesome. Yeah, whatever you share, we'll share with the collaborative. We'll get it into your shared Google Drive folders as resources so folks can benefit from it as well. And I would say, Courtney, and I would say to all of you, try a few on pen and paper, right? Like I know that EMR is a barrier and it feels like that will be so helpful. But if you're still tossing between that SBIRT and TAPS and, you're like, we want to wait for the EMR, don't be afraid to not wait, right? Like, don't be afraid to just try it out, see how it goes, get some patient feedback, get some provider feedback. And that'll help inform your decision along the way and also help get people like really excited about it and feel like it's effective because they've tried it before you build it out on the EMR. You might learn something, right? You might learn that a couple questions could be asked differently before you go to the EMR build place. You might learn that, some questions are more important than others that you might want to highlight or bold or make required. So give it a try, test it out on pen and paper for a little while and see what your feedback is. And that will help you really be confident, when you get to the place of being able to build that in your EMR.
That's a great suggestion. Thank you.
All right, so we only have 4 minutes left and we want to, let's see if I can talk and juggle my screen. We want to make sure that you do use the next few minutes to really give us some feedback about the presentations that you saw today, the information that was shared, all the resources. I am fumbling a little bit. There we go, the link to the survey.
I put it in the chat, so no worries.
Awesome. Thank you, Katie. So you would please just take the next couple minutes, fill out the evaluation, let us know what worked, what didn't. We love quality improvement and we love small tests to change. So we're willing to make minor adjustments along the way to the content, to the learning sessions, to the team time. Let us know what's helpful and what we should toss out. So thanks again, everyone. We appreciate your time. We know you're busy. We love that you're interested in doing this work with us, and we couldn't do it without you. So we look forward to seeing you all at the next